Good morning, everybody. My name is Lisa LaFerrier. I'm the VP of Strategy for Health Cities. Before we begin, I'd like to point out where the restrooms and emergency exits are. Restrooms are out that way, emergency exits behind me, and no, I was never a flight attendant. Also, out of respect for our speakers today, I'd like to ask you all to put your phones on vibrate or silent. And if you have to take a phone call, please feel free to step out in the lobby to do that. You'll notice that on every table, there's some postcards with QR codes. Please use that code to send us ideas, feedback, and partnership opportunities as they come to mind throughout the day. Now that housekeeping is out of the way, I'd like to thank you all for joining us at Health City's first Accelerating Health Outcomes Through Innovation Symposium. This is going to be a really great day of discussion, ideas, and hopefully new partnerships. Given today's conversations will be about unique challenges faced by rural, regional, and remote communities, we felt it was important to host this event outside of Alberta's two largest urban centers. So thank you everyone who traveled to be here today, which I'm pretty sure is almost all of you. We acknowledge that the land we gather on today is the traditional territory of Treaty 7 to the south of Red Deer River, Treaty 6 to the north of Red Deer River, and Métis Nation of Alberta, Region 3. Thank you for welcoming us to your territory. I would also like to acknowledge the discussions we will have today and the work we do takes place across Alberta, which also includes the traditional territories of Treaty 8, the 8 Métis settlements, and the 5 territories within the Métis Nation of Alberta. We acknowledge and give thanks to the many First Nations, Métis, and Inuit who have lived in and cared for these lands for generations. We are grateful for the traditional knowledge keepers and elders who are still with us today and those who have gone before us. I would like to invite Elder Marilyn McGillis from Enoch Cree Nation to offer us a blessing this morning. Hello? Okay.
Good morning, everyone. What a privilege to be here today in a very scientific workshop. And I was just going to share a little bit history of myself. I was born and raised in a community called Hobima, Musqueam. So therefore, I was able to speak fluent Cree. I am fluent Cree, and what I wanted to say, that's such a big gift. I was able to speak my language, and I know there's many various intellectuals here today, and I also went on to complete my Bachelor of Education degree in U of A, University of Alberta, and also I was a nurse before I decided to go teaching. I didn't like the hours in nursing because I had 4 little babies and I had to leave them morning, noon, and night. Morning, noon. I thought, if I'm a teacher, at least I can come home, be with them. And one of them's Colleen. And so I was privileged to encounter, a lot of education, and I still retain my language, which is such a big gift because we lost it. We're losing our language. But Cree is one of the languages that's going to survive. Yeah. And I'm here on behalf with Treaty 6, we have 11 treaties in Canada that were signed years ago. And like I could be standing here telling history, but I'll I'll say my prayer, and I'll have it in my language. And I think this is always such an honor when you're presented tobacco and sweetgrass. And there's also a story on the sweetgrass, but I'm not going to get into it. Why we braid it, and so meaningful, and it's such a blessing. I thank the people that offered me this offering, and now I will say my prayer in Cree.
Thank you, Elder Marilyn. We're grateful for your words of welcome, your presence here today, and the knowledge that you share with us. I would now like to invite Health City's CEO, Reg Joseph, to bring us some opening remarks.
Good morning, everyone. Happy Pi Day. Thank you all for all of you that traveled here today. We're really pleased to be here in Central Alberta. You'll hear on the first panel some work that we've done in Central Alberta that is really moving the needle on health. And we're just excited to have everyone here today. We know that we have some big challenges in healthcare. We know that the current government has made some significant changes on how they're going to look at healthcare. But in this room, we have a diverse group, and it's an opportunity for us to advise how things need to move in healthcare. And it's not just about the technology. Elder Marilyn talked about the intellectuals in the room. It's really, health is part of us and how we live, and it's tied to our community. It's tied to our family. It's tied to the health of Albertans. And we need to have the insights, the knowledge, and the wisdom from everyone in this room so we can drive forward in a way that makes sense. and it has to be connected. And you know this, connection is key if we're gonna have success in health. So I'm really glad that you're all here. I'm looking forward to a really engaging conversation. The panels look really exciting, so I'm really glad to have all of them here, and thank you all for participating. So now I'd like to invite our Master of Ceremonies, Crystal, to come up here. Crystal is a co-founder of Branch Out Neurological, some of you would know. She's also with Thin Air Labs, and she's managing Fund 1 from Thin Air Labs, is that correct? Yep. And she's also, we're really pleased to have her as serving on the Health Cities Board as well. So let's welcome Crystal.
Okay, thank you. I'm already inspired with the speaker so far, so thanks so much. It's great to be here, and I've already heard some people say, wow, it's so nice to see you in person. It's like it's still novel to see people in person, so I'm so glad most of us traveled here so that we could be in person and have engaging discussions. Now, thank you, Reg, for the introduction. Thank you, Marilyn, for a beautiful prayer to start our day, and bless us because we do have a lot of exciting opportunities ahead, and we can take all of that great spirit that we can. I'm sure a lot of you are asking yourselves as you navigate healthcare systems, why is it this way? How can we make this better? And what can I do? What can my organization do to help? And if anyone is asking any of those questions, show of hands if you are. Okay, good. Okay, we got the right crowd, and we also have the right itinerary going forward because that's exactly what we want to focus on. As Reg mentioned, I'm on the Health Cities Board, and it's an honor to work with Reg, you and your team. Throwing this event is an incredible opportunity. I already heard great feedback about the timing so that we can travel, get a lot out of a pretty short window, and then be able to go home for dinner and our other activities. So well organized so far. I came here from Calgary. I am the vice president of the first venture capital fund at Thin Air Labs. Although we are sector agnostic, because the deal flow is so strong in healthcare, half of our portfolio is in health sciences. And I was inspired to start a venture firm after an experience of growing the Branch Out Neurological Foundation from scratch, funding high-quality research in universities across Canada, and that gave me insight into how much R&D, how much IP is being developed in the university labs, how many innovators there are. It also opened my mind to the opportunities of what we can do with all of that IP so that we can commercialize it, change policy, make change, and integrate it so that we have real, not only ROI. As a venture capitalist, you have to look for that, but you also have a new term that I invented called IOI, which is impact on investment, looking at the scalability of these new innovations and how they can be integrated so that we can all benefit at scale. We can be leaders here in Alberta and hope that it spreads to the rest of Canada and, of course, across the world. So without further ado, again, it's an honor to be your MC today, and we have a great panel. First up, it's quite the banger. It's called Modernizing Care, Pathways to Progress. This panel will discuss some of the challenges of delivering primary care to rural, regional, and remote communities, some examples of technology and team-based solutions that have been piloted, and potential areas for further innovation. So our moderator for this session is Dr. Richard Lewanchuk. Dr. Richard is the Senior Medical Director of Health System Integration for Alberta Health Services. In this role, he works a variety of partners to help Albertans be as healthy, well, and independent as they can be in their homes and communities. Love that vision. Prior to this, Dr. Lewanchuk was a Senior Medical Director for Primary Healthcare for AHS from its inception until 2019. He also co-chaired the International Advisory Panel for the Alberta MAPS Initiative. He is a professor emeritus within the Department of Medicine at the University of Alberta, where he still co-chairs the Social Determinants of Health Working Group. I'm going to also introduce our panelists before we welcome them all on stage. First up, proudly representing her Irish roots with bright green pants, is Erin O'Neill. She is the Assistant Deputy Minister, Primary Care, Alberta Health. Erin is a registered professional planner. Now, I didn't even know that that meant urban planning. All I saw was the word planner, which means I collect people like her. She's got over 18 years of government experience, including both municipal and provincial organizations. During her time with Alberta Health, Erin has served as the Operations and Logistics Section Chief for the COVID Emergency Operations Center, where she led large, complex initiatives, including the distribution of rapid tests across Alberta, the border pilot project to reduce quarantine time following international travel, and the COVID lottery. No small tasks. Erin was previously the Executive Director of Research and Innovation, where she led the Project Management Office for Alberta's Surgical Initiative, the development of a Health and Innovation Review, and the creation of Cancer Research for Screen and Prevention Funding Program. Next, we have Lana Solberg, Healthcare Solutions and Partnerships at Boehringer Ingelheim. Lana grew up in Saskatchewan, where she went to university and worked as a social worker for almost 10 years, salt of the earth. She then moved to Edmonton, where she started working for Boehringer Ingelheim in 2005. She was held a variety of different positions at Boehringer and now works in healthcare solutions and partnerships, where she has the responsibility for development of partnerships across the Western region. She does this by co-creating healthcare system collaborations that improve patient outcomes and system efficiency. Over the past 6 years, Lana has championed numerous partnerships across the Western region, including 3 partnerships with the University Hospital Foundation and Government of Alberta around respiratory disorders, another one with Central Zone PCNs, Health Cities, and Alberta Innovates to deliver chronic disease management virtually. Wow. Okay, next, and finally, we have Jody Tazenbitz, Operations Lead, Central Zone PCN Committee. Jody has over 20 years of experience leading projects and people in health, nonprofit, and academic teams across a variety of areas, including public health and rural primary care. For more than half of her career, Jody focused on chronic disease prevention and social determinants in health. For the last 5 years, Jody has worked in the Alberta primary care system, supporting Central and South Zone rural primary care networks, physicians, and multidisciplinary teams to build capacity and implement system change related to opioids, chronic pain, mental health, home health monitoring, and governance. I told you this one would be a banger, no questions. Welcome to the stage our panelists and moderator.
Good morning to everyone. I'm very excited to be here. I think this is going to be a really, really interesting day for us, as we've heard. But despite it being a good day for us all collectively, for me, it started off as a bad day. You know, have you ever had one of those days? Well, the first thing was I got halfway from Edmonton to Red Deer and I realized I forgot my suit jacket. Then the second thing is that I figured I needed a pen to take notes or write notes. So in getting my pen, because in my role I often seek the wisdom of elders, I always make sure that I have a pouch of tobacco. So as I was grabbing my pen, I grabbed the pouch of tobacco from the bottom, and now the inside of my car is covered in tobacco. So I'm waiting for the third thing to happen, and I think what's going to happen is I'll probably get pulled over by the police, and they're going to see this stuff that looks like tobacco, and you can complete the story. But despite that, I think it'll be a great day. Just a few words to sort of set the tone and get us going. You see that the title of the session today is Accelerating Health Outcomes Through Innovation. And so the number of key phrases that have been used in promoting today, things like modernizing care, which probably should be futurizing care, improving outcomes, cutting-edge technologies, groundbreaking models. So what does that actually mean? I thought I would maybe deconstruct it. So we talk about outcomes, and we hear these comments like, we are spending more money and we don't have good outcomes. Well, what outcomes are we actually talking about? Well, you heard in the area of AHS that I work in, our outcome is to help people be as healthy, well, and independent as they can be in their homes and communities. But quite often in the health field, we're thinking in terms of our outcomes relate to, did we fix broken things? So we measure that in terms of, did we decrease visits to the emergency room or hospitalizations or length of stays? But I would suggest that maybe those are measures as opposed to outcomes. If we do things right and keep people healthy, then they don't have to go to the emergency room or be admitted to hospital. So maybe we need to rethink a little bit around the outcomes. In healthcare, I don't know if people have heard of the term of triple aim or quadruple aim, or even now it's quintuple aim, but it looks at the aims of a healthcare system. And so beginning there, we talk about the first aim is to improve patient experience. And it doesn't mean does the doctor's waiting room have up-to-date magazines, and no waiting rooms have magazines anymore, but you get the idea. It's, did people get the care that they really wanted and needed in the way they wanted it in an efficient manner? The next outcome is population health. Did we improve the outcomes of the population or the health of the population? And it may come as a surprise to you that in the last at least 20 years, none of the high-income countries in the world have actually changed the health outcomes of their populations. And that relates to the QUIN, or the number 5 that we'll talk about. The other one is, did we decrease costs, is what's often said. And I often also say that if your whole goal in the healthcare system is to decrease costs, you can do that in a minute, 1 minute. Just lock the doors to the hospital. That'll cut your cost by 50%. There's your outcome. But obviously that's not the outcome we're looking for. The fourth part, if you're talking about quadruple aim, is provider experience. Did the people who provide care, are they able to provide care in a meaningful way that's rewarding for them? And now the quintuple, the final part, has to deal with equity. And so for years we've provided care to those who can get care and to whom care is accessible. But do we really think about those who cannot get care? And it's not just about care, it's equity in health. Everybody has a right to health as well. So there's, as we've heard, rural versus urban inequities. There's sort of Edmonton, Calgary here, and everybody else over there in terms of equities. Equities in terms of a person's income level. Often people lower income don't have the same access to both care and health as others. Age, or First Nations versus non-First Nations, all of those factor into our outcomes. So how can we sort of redesign or mature our system, I guess is a better word, or evolve our system to provide those sorts of outcomes, and what are the outcomes that we're trying to work with? And then the second part is related to cutting edge technology and new models. So what are we trying to do? Where are we trying to go? Often in terms of future of healthcare, we talk about technology. So how can technology be applied? And for years, we've been talking about technology and personally been involved with technology, but it's often in the circumstance of, here's technology now, here's the solution, let's find a problem. And probably we should be thinking of, here are the issues, how can we use tools like technology to solve those problems? And the opportunities are endless in this day and age. Everything from virtual care, remote monitoring. We had a little discussion of how we can use drones to deliver things to people or carry things from one site to another. Robots are providing care in Alberta in some circumstances. And another big feature of technology has to do with data and having access to data, because we've heard about things like machine learning and artificial intelligence. We often get a little bit scared when we hear about that, but it's really just using existing data and synthesizing it for better outcomes in that way. So for example, even here in Central Zone in Red Deer Emergency, they're using artificial intelligence to monitor the discussion between the doctor and the patient, and it provides the report. But what artificial intelligence can do, it can pick out key phrases. So when I went to medical school a million years ago when dinosaurs roamed the earth, we were always taught that if a person said, "and it feels like there's an elephant sitting on my chest," that means they're having a heart attack. We were taught that 40 years ago. Oops, I guess I just dated myself. But, and so artificial intelligence can pick out these key phrases and say, hey, you got to pay attention to this. So there's a lot, that's just one example. There's many, many other examples. And then new models of care. Our cliche of cliches, doing the same thing and hoping for different outcomes. We know that we can't do that. Everybody knows that. So what are some new models of care? And, we hear about challenges with health workforce and physician recruitment. And part of what I do, I work internationally or belong to international organizations. I can tell you every country in the world is in the same boat. So doctors are going to the south of France to practice at 2/3 of what they can earn in Alberta. So we're not going to recruit our way out of this. We have to think of different models of care. Same thing with nursing. Number one profession in the world in terms of need is actually personal care worker. And there are not enough personal care workers in the world to hire because every country needs personal care workers. So we need to do things differently. And that's what part of our discussion today will be about from our experts, to get their thoughts and opinions in these areas. Can we do things differently? How can we use data to inform what we're doing? How can we use technology to get to where we're going? So I'm going to join the chairs, and we will start with our panel discussion. So I guess the first thing that we want to do is maybe we can start at the far end with Erin, and if you want to give a minute of opening remarks and thoughts.
Sure, thanks, Richard. I really appreciate that you called us experts. These two ladies to my right are, but I'm not going to claim to be an expert anytime soon. But thanks, Reg and Health Cities, for having me today. It's really interesting to be and insightful to be in this room with other innovators. I think we are refocusing our healthcare system right now and changing things, and it's a really exciting time for primary healthcare. What we have right now in our system is not where we need to be. And as we refocus the healthcare system, I think this gives us a really great opportunity to change and collaborate and innovate with all you folks in the rooms and, industry partners and primary care networks. So it's a really great opportunity, but I think the biggest challenge is we got one shot at this. I think if we get it wrong this time, we really missed the boat. So we really need to do it right. We've made some investments in primary care. You all saw the speech that, budgets aren't exactly where we'd like them to be. So that makes things challenging, but there is money in the budget this year for innovation and primary health care and those things. So it's a really exciting time to work at Alberta Health in primary care. It's an exciting time to be in this room, and really thankful to be on this panel and hear some ideas today from all of you about where we can go, where we can move this, and how we actually do get it right. Because I always said this is our one shot to do it. So we kind of need to hit it out of the ballpark with this one. So thank you.
Thanks, Jody. Or Erin, sorry, yeah, Jody's next.
We took off our name tags. We thought they looked kind of dorky, but now we've presented this terrible challenge for our facilitator here. Thanks for having me. Also not an expert, but I do get to work with a lot of wonderful people across the primary care networks in Central Zone and South Zone. I'm super excited we're talking about regional, rural, remote. I think we really do need to be conscious of the unique challenges that rural remote presents. Some of the things that Dr. Luanchuk talked about, the shortages of physicians it's amplified in rural communities. So if you lose one physician in a rural community, you might have half or your entire population out of luck in terms of a primary care physician. Sometimes they're out of luck in going to a hospital because our primary care physicians in rural communities wear multiple hats. They're your family doc, they're your emergency doc, they're your mental health clinic. So preserving that is really tough situation when everybody's struggling with a supply of healthcare workers. That said, what I've had the privilege of working with the Central Zone PCNs, and the innovative spirit that I've seen is unbelievable. And I think what the small communities really do incredibly well is they have to be efficient. So they're partnering in ways that we all should be partnering across organizations and making darn sure that nobody's doing the same job across organizations. They have to be lean, they have to optimize the roles, they have to look for those opportunities for innovation. So I've seen an unlimited willingness across Central and South Zone to try out new innovative ideas, and we're going to talk a little bit about that. But one of the really big ones is how they work across organizations and build those partnerships to really change the way care is delivered. So lots of opportunities there.
Thanks, Jordy. And Lana.
Sure. So I just wanted to focus on why public-private partnerships can be truly beneficial to the patients in rural and remote areas. And for those of you who don't know, Boehringer Ingelheim is a family-owned pharmaceutical company. So that really allows us to look to the long term, or plan in generations. And so we're able to partner with PCNs and government to really try things that the system otherwise would not have tried, because maybe the government doesn't have all the answers, or the system doesn't have the capacity or the resources to do these proof of concepts. So we can step in and help to try to test out some of these innovations, then measure the outcomes, and then go back to the government and say, hey, look what we've done together. Why don't you kind of embed that into the system so that we can make a difference for these patients moving forward? And I really think we all have that end goal in mind in terms of the patient is at the heart of everything we do. So why not just work together to accomplish that? And over the last few months, I've been to numerous events like this, and everyone keeps saying we need to work better together. And so I think this is an opportunity for us to do that and really focus on partnering and really looking at how we can do amazing things if we work together.
Great, thanks. We'll start again at the far end then with Aaron, and here we are today. I'm meaning not just in this room, but here we are in Alberta. Actually, globally, we've sort of had the same sort of healthcare system for decades. We are where we are, but I think everybody's come to the realization that we need to do things differently. So, do you have a sense of as representing the system and government, where we need to be going, where we need to be looking, the sort of things that need to be considered, and what's the desirable end state?
Yeah, thanks, Richard. I think we really took this to heart about a year and a half ago when we started our Modernizing Alberta's Primary Healthcare System Initiative, or MAPS, as I'm sure most of you know it by. And what we did is we really said, what do we need to do? What does our 10-year roadmap to move primary health care forward? We're not there now. We're not even close to being there. But where do we need to go? What are some early innovations, some early investments that we can make to start to stabilize the system and then strengthen the system? So I talked a little bit earlier about our goal to refocus the healthcare system. The brilliant thing about when we announced the refocusing for healthcare, at least for primary care, it was already in the MAPS report that we needed to create a dedicated primary care organization. So that has actually moved pieces on primary care forward already. Now, AHS does great work, and there are great people working in primary care at AHS, but it's not enough. So when we carve the things out of AHS and move them to the primary care organization, there's still so much more that we need to do to actually move the needle on primary health care. Some of the things we've already done is investments to help physicians stabilize their systems. We've created an Indigenous innovation grant funding. We are working this year, and you'll see coming out in the next couple weeks is our 2-year implementation plan for MAPS. And what does the first 2 years look like? And those are the foundational pieces, because given it's a 10-year roadmap, what do we need to do in those first 2 years to set the foundation? So it is a lot around creating that organization and moving it forward. There will be innovation funding dedicated for primary care. In my past role, we did an innovation review, and that was one of the things that came out, that there is a gap truly in primary care, that you need to have some dedicated innovation funding. So we're working with our colleagues across the department to institute that. Working with our colleagues on the workforce pieces. Like Jody's not wrong. There's challenges in all the areas. They're certainly amplified in the rural and remote areas. And you'll notice in MAPS, if you give it a dedicated read, and it's long, I get it, I appreciate that. The executive summary is a good spot to start. But rather than specifically saying, here's our exact objectives for rural and remote, we actually weaved rural and remote through the entire thing because we didn't want to just have it one dedicated spot that you say, you have to do this for rural and remote and everything else is different. The reality is it needs to be weaved through all of our pieces and it needs to have that dedicated consideration. So you'll see that also when our 2-year implementation plan comes out, that it's really those foundational pieces and it sets that rural and remote is really weaved in through all of it as opposed to having specific milestones for rural and remote, knowing we need to dedicate specific resources to that, but we didn't want to just kind of carve one piece off and say, yeah, that's rural and remote, check, because you really just can't check a box that. So I'm really excited that we're moving this forward, that we're moving forward on the 2-year implementation plan, and that the government has really committed. And we did maps, and then we didn't just put it on the shelf and say, okay, great, that was a great document, move forward. We have really kind of put our money where our mouth is for pieces or that, and to move forward on some of those things. So you're going to continue to hear about maps. It's going to continue to drive primary care. And I know I said it already, but we got one chance at this, so we need all your help in the room to really make sure that that we get this right here in Alberta.
Thanks, Erin. That today gives us a bit of a sense of optimism, or probably should. We often get caught up in the negative and what's wrong and complaining, but yet we're hearing, okay, let's forget about that and look forward and see where we could go and what the opportunities are. So Jody, you already alluded to some of the innovative things that are going on in Central Zone, South Zone, and the rural primary care networks where, they've just said, okay, we're going to have to do something differently. We're going to have to do different things. Could you maybe, I'm sure everybody's curious to hear what some of those things are and what some of the thinking is that underlies some of these innovations.
Sure, thanks. Well, I am super excited for primary care to get its own pillar, as we're calling it. I do really hope we can make a special focus on rural remote because a lot of those tables, it's really hard to get the rural remote regional voice heard. It's just the urban voices tend to be louder, so look forward to working on that. But I have had the pleasure of working with such amazing people across the zone. So one of the things that brought me together with a lot of the people here, Health Cities, Boehringer Ingelheim, Alberta Innovates, was a wonderful project we got to do in the beginning of COVID, was our home health monitoring project. So we got funding and support from these organizations during a time when access to primary care was particularly challenged. It already is, and already certainly always is in rural remote with geography and connectivity challenges and weather, all kinds of things. So we had the chance to rapidly deploy this home health monitoring initiative, which is essentially a hybrid of using technology and team-based care to offer better access to healthcare, skill development for individuals, keeping them out of the hospital. Everyone involved, which was primary care nursing teams, working with their docs. It was a great example of how you can optimize roles. You don't need a physician to do everything. We had PCN nurses, LPNs doing this monitoring. And so it was a really wonderful project where the patients loved it, the providers loved it, and they moved fast. Like the primary care networks, even though they were operating often on a shoestring, they moved really fast. Their teams were excited. They got to do it. There's a million other examples across Central Zone of innovative opportunities. Kalina Country PCN, then Executive Director Brian Match is here today, has done amazing work on reducing impact of financial strain. The Red Deer PCN has some great work around a memory clinic. It's called the Mint Memory Clinic. That's another team-based care example. All across the zone over the last 5 years, we've also made some huge advances in youth mental health. We've trained up a huge range of professionals, physicians, and they've set up little clinics. We have, maybe not a surprise to many of you, a mental health crisis along with our healthcare and primary care crisis. But there's little clinics that have been set up all across the zone where doctors have got just a little bit of extra training so that they can help kiddos who are experiencing mental health challenges. And all these little seed projects across the zone are just sitting and waiting for just that little bit of extra resources to take off and hit that sustainability point. So I think the sky's the limit. The appetite is there. We just need the attention and the funding models.
Thanks very much. And Lana, in Alberta, the media trains us that you're not supposed to talk about private and business and whatnot. And yet, if you think about it, all our technology innovations, all of the new drugs that we have, it all comes through business and private industry. So how do we partner, the private sector and the public sector for the good of the population? I know you've had experience with the home health monitoring project. So how do we work together in productive partnership?
Yeah, I mean, I think like Aaron said, we have one shot, and we can do it together. And I know there's this perception that maybe pharma is the devil or not someone we want to work with, but I think how I got introduced to these ladies is during the pandemic. This was PCN that reached out to me because they knew the type of work I do in the ecosystem, and they were like, what can we do to monitor our complex chronic patients at home? They're not coming to see their family physicians because of the pandemic, and so how can we work together to really test out this new model of care? The PCNs already had their chronic disease management programming, but could we deliver it virtually? And so then I was able to bring together multiple people. I mean, we didn't fund it all. Alberta Innovates put in a lot of additional funding. Obviously, the PCNs did all the intensive work around change management and implementation, and the government, actually the Ministry of Seniors and Housing, actually provided additional funding because they wanted to look at alternate models to supervise these elderly patients in their home. And like Jody said, I don't want to repeat a lot of that, but huge results and great outcomes in terms of patient and provider satisfaction, reducing healthcare utilization, keeping our elderly patients off these rural and remote highways in winters in Alberta, because none of us like to be on them. And so if they can be monitored from home, earlier interventions, the nurses can make changes or whatever that needs be. And I just feel like because we are privately owned, Boehringer family really does have that value of investing early on, being proactive, making the healthcare system more sustainable. And I do really feel like it's a responsibility of industry to really help out to make a difference to try to improve some of these patient outcomes.
Great, thanks. I said at the outset that we often have technology and look for the problem, to match the technology. But given what all of you have said, if we sort of flip that around and think of, okay, how can we use both technology and new models of care, as you've mentioned, Jody, to bring care to the people rather than having people come to the care. So we've historically had this, okay, well, you need to go to Edmonton or Calgary for this service or that service, or I've done a lot of work in First Nations. If you're up in Peerless Lake or Trout Lake in northern Alberta, you have to drive 2 hours to get to High Prairie, and there's no transportation, and you have to pay $100 to get somebody to drive you, or many communities have no road. How can we think in terms of different models and optimizing technology or leveraging technology to bring care to people? And it doesn't need to be just remote rural, even people who are homebound. Be interested in your thoughts, so any one of you can start.
We're going back in order. I thought we were going to switch it up.
I can start if you want to.
We'll go backwards.
I mean, I think the good thing about partnerships is we were able to test out this new delivery of care. We brought in some resources internally. Everyone else participated. And I think that really showed the opportunity that we can do these things, right? And it's possible to accomplish more when we do work together. Patients loved it. They were asking for it. Then we have all these great outcomes, but the issue is some of the PCNs, like Kalina Country, were able to operationalize it because they did have maybe some extra funding, but I think we need to really look at different flexible models around staffing and the capacity for change management and what that looks like, right? And so I'm hopeful and optimistic with this new primary care entity and really a focus in primary care, and maybe that will also help break down some of these budget silos in terms of really putting the resources where they're needed, because we can't expect people to do this off the side of their desk. I mean, it's just not possible. So this was successful because we had the funds and the resourcing for them to do that. So.
Yeah, this was successful, but we don't have the funds. I keep looking at
True, we still need
the
them.
person who's going to get us the money here. Although we did get money from a variety of organizations. It was an amazing partnership, and we show is a proof of concept. I think a lot about innovation and the amazing people that I work with in primary care, and I'm not an expert in using all the new technology, but I think, there are primary care folks, they're up for anything if we have the resources to do it. I mean, the reality is this beautiful project, beautiful partnership is not sustainable yet. We had quite a few of our PCNs were not able to continue doing it. Some can, and they're cobbling together resources to continue doing it. When I think about innovation, a lot of the pieces that I think make it successful don't sound very exciting, but they're so important. And so, sustainable funding, obviously. But I think another thing that I had the privilege to do over the last 6 years was focus on the change management skill set and helping people do that. So that obviously we want to fund nurses and doctors, and that's really, really important. But if we can also create positions that support the innovation change process and help that, I think that's so important. I see the leaders of our little PCNs, doing it off the corner of their desk, trying to find the time to do it. But we don't often think about funding those other positions that will really, grease the wheels of change. The other thing is, I think that we've started, and we collectively across all our organizations have started using some pretty sophisticated technology. Connect Care, you may have heard, has been rolled out in AHS, and I was talking to some folks who work in acute care the other day, and they were saying, we did roll it out, and we rolled it out fast, and we rolled it out well, and it's a great tool. But we, are not talking about how to optimize it. We're really only using 20% of the capacity of these amazing tools to do it, and where's the staff, where's the energy, where's the time to do the other 80% of deployment that will really take us into the whole new world of communicating across organizations, and saving all those little minutes of time. We don't know where we're going to invest that. Home health monitoring, we had this beautiful chronic disease program, but it can be used for mental health. It can be used for more acutely ill patients. It can be used for, new moms or moms to be. There's really unlimited application, but we kind of are living in a land of pilots. So I just would not want to forget that we have all these beautiful innovations. Some of those mental health clinics that I talked about, we have our little teeny-weeny provost, a PCN, operating 2 afternoons a week. They're full up. The kids are lined up. The parents are lined up. They just need more money to do it 5 days a week instead of 2 days. So some of those things that are not as, exciting and sexy, or they're just administrative supports that will free up the energy and the time to allow us to, take that spirit of innovation I see already across the zone and actually spread it and make it real.
So similar to Richard, when I was on my way here, I realized that I forgot my bucket of money too. It's with his sports jacket. But I think Jody raised an interesting point. I think one thing that the government does really well, and the one thing that we do, it's like a double-edged sword that we do really bad, is we love a pilot. So we do these pilots and we invest in these pilots, and then how do we sustain the pilot? So I think that's a big piece of where we're going, certainly in the innovation space too, of, we may actually stop funding pilots if we don't know how we're going to sustain them, because home health monitoring, it's an amazing example. Health cities, Alberta innovates PCNs that they do, but now we have this great thing that everybody wants that we don't know how to sustain it, and there isn't, unfortunately, a large bucket of money. So, and I don't know how we do this right, but one thing we are really talking about right now is how do we invest that we know there's sustainment in the long run? So what do you do from day one when you're designing the pilot or designing the concept that actually takes us so that when we get the better health outcomes, we get the patient satisfaction, we get something that patients are asking for, how do we make sure we can give it to them and we can spread and scale it to other PCNs or other areas of the province? because it turns out to be a really great idea and it works, and we're seeing progress from it, but how do we change that? So it makes it really challenging, because all of those things we would like to fund, but we can't. So I guess the challenge I put out there is, how do we do it from the start? And if there is money for pilots, how do we do those from the start to make sure that they're sustainable in the long run?
I just want to follow up on that P word, the pilot word. It was, we've heard it goes back to Monique Béjean saying, Canada is the land of pilot projects. But I was in a meeting, international meeting about 3 years ago of health systems, and they had one, every health system said, what is the number one challenge to healthcare in your country? And unanimously, it was pilot projects. We have these ideas and these innovations, but we just can't make them mainstream. So here's the challenge. What do we need to do to make the mainstream? Or as you say, do we need to, forget the pilot projects? Let's do the Yoda principle of, we either do it or if we don't do it. And if we do it, let's just keep modifying so it works. How do we make that leap? How do we redirect our resource? Because again, it's, we also realize, there isn't that bottomless bucket of money. So how do we use what we're doing now to do things better or differently?
And I think that's the hard part, like the double-edged sword. When we started HHM, we had that in mind, obviously. We don't want to do another pilot, but this was a huge need during the pandemic. We sat down and went through what do we need to measure to show the government, to show the system that we're maybe cost avoidance, cost savings, improving health outcomes, less ER visits. But it's hard when the budget is acute care. Yes, we're saving bed days, but they're not going to give that to the primary care to pay for the innovation. So I do feel like we did have that end goal in mind. And then there's some struggles about accessing the data to show those outcomes. So the government's saying, well, we need to see outcomes to fund things like that. But when the primary carers can't even access the data, it makes it hard. So I think we all know that. It's just like figuring out that way. And I don't have the answer, but I think kudos to the Alberta government and Alberta, though, because they are providing a very inviting environment for industry and others to really sit down at the table with them. They're willing to listen. They're transparent about their priorities and saying, like, how can we accomplish this together? And that doesn't happen in other areas, in other provinces. So I would say to you and put out to the government, continue to sit down at the table with us. Also very open in terms of the MAPS Indigenous Innovation Fund. Boehringer does a lot of work with our pathways that you'll hear about later, but really providing these resources for Indigenous communities to make a difference in addressing the issues that they've identified themselves. So I don't know that I really answered that question, but...
Yeah, I don't know if I can fully answer it either. And I'm just teasing you about the money, because I know there isn't a bottomless pit, and of course we have to prioritize. But I do think, in rural, remote, regional, the typical funding models do put us at a disadvantage. So, typically you get pots of money, population-based funding, just the way it works out, I do see that some of these amazing things that we do are easier to sustain and implement in the urban settings, and because they have economies of scale that you just don't have in rural, remote, regional. So I think there is something about the funding model that does have to be different to incorporate these elements of change in rural, remote, regional. So I think that you have to acknowledge that, when you're spread out, it costs a certain amount of money to set up an organization. You need a building, you need an executive director, you need, and then if you're working on a population-based funding model, there isn't often much left after that. So I think that some of the solution is in a funding model. And then the others are some of those things that I think, creating positions that specifically support starting, sustaining. I don't think we can get completely away from a pilot project. Pilot projects is we're trying something new. We want to keep trying something new, but if you build it into the system where you can consider it really a quality improvement exercise, make it a little bit easier to flex the way money is spent. Sometimes it's really, really hard to justify or make a case for iPads. It sounds silly, but iPads and phones were a part of this home health monitoring exercise. exercise, but we're not allowed to put those in certain budget lines. So then you have to get super creative and hold out your tin cup to Boehringer Ingelheim, to pay for the iPad. So I think there's some tweaking that you could do to the funding model that would just facilitate that a little bit more in central, southern, northern Alberta.
Yeah, and I guess the one piece I would add is I think collaboration is key in this. We're sitting up here today with industry and PCN and the government, and I think we need to keep doing that. And that's the only way we can do that is if we work together to move some of these things forward. I don't disagree with anything that my co-panelists have said today, but we're in such a challenge. Like, how do we work together so we move these things forward, and how do we take those good ideas that somebody has and figure out how we pay for the iPad or those types of things. But we need to do it with collaboration, and we need to do it together so that we actually truly do get that primary healthcare system that we've put out as our vision.
I want to just pick up on your collaboration thing. So I think that is just so critical. And one of the things I got to do over the last 6 years was focus on how we could do that across across PCNs, across primary care to AHS, mental health to AHS, primary care. So I will certainly be hoping that as we build these beautiful new structures to focus on addiction, mental health, continuing care, primary care, acute care, that we are working really, really, really hard to figure out how to make sure that we're not reinventing the wheel in each one of those organizations. Some of that stuff I started talking about initially, about what little tiny communities do so well is make sure that only one person is doing these things and we don't have these built-in redundancies. Now we have to do that across multiple giant healthcare organizations. And that's not easy, and that takes the same kind of attention that, I've talked about with change management. You need people whose job it is to actually make sure that those partnerships are happening. So I look forward to seeing how we crack that nut.
Yeah, me too. And I think to add to that, I really think at the end of the day, it's really about the patient. The idea is we have these 4 new organizations, but the patient should know there's 4 new organizations. So how do they work really together? How do we collaborate across the organizations? One, to do what Jody's saying of, we can't go backwards. We don't need to reinvent the wheel. We've learned a lot of stuff. So how do we continue to do that? But how does it improve patient outcomes, and how does it not impact the patient, because there are 4. So I know that's one thing that we're really working hard on, and we need to get it right, and we need to do it off the top. So that's it's inspiring yet scary all at the same time.
Well, thanks very much. I think that's a keyword in inspiring. So I'd like to thank our panelists for their thoughts. I think this really gives us a sense of optimism and hope for the future, because what I perceive is we really are now seriously thinking of how do we do things differently? How do we design the system for the future? Forget about complaining and deconstructing the past, but let's look to the future. Lots of examples, lots of willingness I hear about moving forward. So thanks to our panelists, and we look forward to hearing more from the next panels and presentations. Thank you all.
Thank you.
Thank you, everyone. Test. Thank you, everyone. What a great way to start up the conference. I heard a lot of work around collaboration. I heard a lot about being creative with how we fund, when we fund, where we fund. It's not just about more funding necessarily. It's about being really strategic and focused and thoughtful about our priorities. So thanks again. And our next panel I'm very excited about. It's our second panel. The title is Indigenous-Led Innovation in Primary Care. Now, this panel will discuss what change can be initiated to achieve health equity in Indigenous communities and create better access and safe spaces in the healthcare system for Indigenous people. Across Canada, Indigenous-led innovation is reshaping the landscape of primary care and driving transformation in healthcare delivery. Throughout this panel, we'll discuss the unique approaches, challenges, and successes driven by Indigenous communities and examine how these experiences are paving the way for improved primary care access for all. This panel provides a compelling and meaningful journey into the forefront of healthcare innovation. Now, in this spirit, of rewriting the script of the future of healthcare for the better, we have our moderator, Colleen, who rewrote her script in her bio for the better, and I am going to read her writing. Colleen McDonald is our moderator and head of health management and support of the Enoch Cree Nation. She is a proud Cree woman with over 25 years of experience in the First Nations health admin. Currently, she sits as the health co-management table as co-chair of the Health Protection Subcommittee, as well as co-chair of the Mental Health and Addictions Subcommittee. She has also been engaged to sit on the Alberta Region First Nations Opioid and Drug Poisoning Task Force. Historically, Colleen was part of a national team who brought Aboriginal Head Starts on reserve. She also was instrumental in developing Head Start plus a daycare to the Treaty 8 First Nations of Alberta. Her current role as Senior Manager of Enoch Cree Nation Sovereign Health involves the building of a state-of-the-art medical campus which includes surgical facility, diagnostics, lab and radiology, traditional medicine, pharmacy, mental health clinic, and a traditional birthing center. She brings to the health landscape a grassroots perspective as well as a strong lead in instrumental relations and partnerships intergovernmental relations and partnerships that are building. The truth she speaks in We Cannot Do This Alone is that we cannot do this alone. I'm going to skip that, I can't read it. As long as the sun shines, the grass grows, and the river flows. Feels like I'm reading poetry. Thank you so much. This is Colleen, our moderator. And with Colleen today, we have Dr. Cassandra Gallant, Manager, Clinical Operations and Implementation at the Arthritis Society. Dr. Gallant is forward-thinking medical professional with a passion for innovation in medical research. Armed with a strong background in medical imaging and dedication to advancing healthcare, she's committed to harnessing cutting-edge technologies to shape the future of medicine. By bridging the gap between medicine and technology, Dr. Gallant seeks to catalyze transformative change in the field of radiology, ultimately paving the way for a healthier and more resilient future. Next, we have Stacy Strelchuk, Principal, 143 Healthcare Consulting. Stacy is a healthcare executive with over 25 years experience in the government, healthcare, and not-for-profit space. Stacy served as Executive Director for the Camrose Primary Care Network from 2008 to 2019, collaborating with patients, stakeholders, physicians, and healthcare professionals to provide enhanced team-based primary care. Good governance and acting as a system convener remain a focus in her current position as principal and co-owner of the 143 Healthcare Consulting. In 2022, Stacy was appointed by the Minister of Health to the 20-member Provincial Strategic Advisory Panel tasked with presenting recommendations to modernize Alberta's primary healthcare system. Lastly, we have Amanda Miyawasiji, Director, Intergovernmental Relations and Community Engagement for the First Nation Health and Social Secretariat of Manitoba. I believe she's from Manitoba. Yeah, that's exciting. Welcome. Amanda is a proud Anishinaabe from Eagle Lake First Nation in the Treaty No. 3 territory in Ontario. Amanda currently serves as the Director of Community Engagement and Intergovernmental Relations for the First Nations Health and Social Secretariat of Manitoba. Amanda has been advocating for the advancement of positive health outcomes for First Nations people in a professional capacity for over 20 years. A lot of people with over 20 years experience, wow. Holding senior positions regionally and nationally for the Assembly of First Nations. Amanda believes it is imperative First Nations people are included as equal participants as it pertains to the planning and implementation of health system response and strategy. Please welcome our panelists and moderator to the stage.
Danse, everybody. Good morning. Colleen McDonald is my English name that I was, but my ceremonial name is Kehiu Esquil. So Danse, Kehiu Esquil Nesigasan, Muskeksa Kotsinia. I'm from the Enoch Cree Nation, And my name, spiritual name, translated in English means eagle woman. So when I asked the elder, what does that mean? Why give me that name? He said, you see things from afar. You have a vision. You can kind of almost have an intuition of creating a pathway forward. So I'm humbled to be here today. It's also an honor. And I'm a little stubborn, so when I'm talking, if I sound like I'm scolding you, I'm not. It's just that I'm passionate about the work and the importance of it. I want to say welcome to the panel. And and I know it's tough when you're trying to read a different language, so an acknowledgement, Anishinaabe, did I say that right? And that's from the Treaty 3 territory. And I bring to this table a grassroots lens, like I spoke in the introduction. And in my defense, in a way, I was approached less than 48 hours ago, to some capacity, to be here today. So just rewriting the bio and committing to being here, I had to juggle my home, they're all sick right now. But I wouldn't have it any other way, because I think that there's a purpose and I don't see things as a coincidence. I know that we want to talk about what changes can be initiated to achieve health equity in Indigenous communities and create better access and culturally safe spaces and ethical spaces. And I talk from my heart. So a lot of times I take the paper and I flip it over because it's a bit of a challenge, and I like to read the room and make eye contact. So that's important to me. And I want to also talk about, we heard earlier about the social determinants of health. It's a little bit more complex than First Nations communities. We have, not every community has access to clean drinking water. And that's a basic life necessity. You're talking about families who may be 10 to 12 people living in one household, and not by choice, not because they're pitching their money in together to pay off a mortgage and just working different shifts. It's because we have a housing shortage. And then there's also questions around education. And sometimes we even feel, and I'll just say it, no offense to government in the room, the carrot gets dangled, and we as First Nations are at this table, and it's almost like we're fighting over managing our own poverty, if you will. And I'll say that lightly. But I also want to say this: nothing for us without us. We have to work together. And I know that sometimes there's an elephant in the room, especially when you're talking to our leadership, and out of respect and not trying to step on anybody's toes. There's also a fear-mongering that goes on when we talk about private sector or partnering with the province, because we are protectors of our treaty right to health. And I used to say that, I used to kind of blame the leadership in a sense, like, what are our leaders doing to ensure that the medicine chest is protected? But I have a responsibility as a mother, as a daughter, as a grandmother. I too have a due diligence, not only to protect that treaty, but to revive it and rebuild it and breathe life back into it. And I know that's a tough one, because I've heard it time and time again with our over 100 of years experience on this panel. Can you imagine? So, government doesn't often like to hear that. So I say it gently, but I also say it respectfully. Because if we are truly in it together, we will work together. And there's space, an ethical space for each and every one of us. We talked a little bit about our medical facility. And I'll kind of wrap it up here, because I have to be out by 12:30 to take an important call. And then I'll be back. Creating that safe and ethical space to have each and every one of us heard, build on those partnerships that are sustainable. We have numerous pilot projects. Our state-of-the-art medical campus will include hip and knee replacement surgeries. We're looking at a birthing center. We're looking at pharmacy, as well as our traditional medicines, having access to our elders and ceremonial spaces as well. So, and it's not just for our people, it's for all of us. If you want to be part of a pathway forward in health that is unique, the first of its kind, I'm going to put my money on it, in Canada, if not in the world, to be honest. So I welcome you to be a part of our journey, as well as creating a safe and pathway forward for Indigenous-led health service delivery. Thank you. So I guess I'm supposed to sit now. Check, it's on? Okay. So what we talk about is innovation. This one's for you, Amanda. Innovation has existed in our communities for generations. We have solutions and the knowledge. What we need is to find a way to facilitate the dialogue and partnerships. What are your thoughts about that?
There's been so many good commentary from the previous panelists as well as yourself, Colleen. I think one of the biggest challenges that I've seen, so that's a little bit of a background. The reason I came here today was as a result of a partnership that I work on with Boehringer Ingelheim Canada, along with a group of First Nation health experts. And I think there's a lot of interest from the public and private health sectors, the public investment. I heard about a fund today. It has to go beyond government. And what we've seen is that I think fear is a big impediment in creating and bridging a lot of these relationships. So what we've done is we've created a health fund that will, address some of the innovation projects across Canada. And we did an open call for projects, and we received 30 applicants. And I thought that was pretty amazing that there's 30 innovation projects that are happening with respect to Indigenous healthcare. And unfortunately, we only had the funding to support 4. And so for me, I feel like there is a need to create that space for interested Indigenous communities to meet with the public and private health sectors, along with government stakeholders, to say, how can we create partnerships and collaborations that are based on mutual respect and reciprocity to remove that fear, because I think there could be such amazing collaboration between our communities. We have the fastest growing demographic of the population that should be at the forefront of these technological innovations. And so for me, that's one of the big things, is removing that fear and creating that space to have these dialogues between these different stakeholders, but also that the investments need to match the outcomes. So for example, our communities are super interested in technology and using technology as a bridge to healthcare, but we need that investment to our young people. Our young people need that training. They need that access to the laptops and the iPads that we were talking about. And I've had the privilege of seeing such innovative projects come from technology with a focus on prevention, and I think that's where we need to go, and that innovation at the community level is actually common sense in our Indigenous communities. We just haven't had that opportunity to put that into practice and to be supported to allow that innovation to flourish. So a little bit of a rant there as well, but hopefully I answered that.
No, that's great. I think I might have been approaching this a little bit differently, but I'm going to move over to Cassandra and for your opening remarks and about ensuring health equity in Indigenous communities and in a way that protects and that are Indigenous-led.
Perfect. Yeah, I'm so excited and grateful to be part of such meaningful conversations here. And being a newly trained physician, I'm kind of at this looking at the outside looking in, and I'm just, I'm looking into my future, and how can I make this better? How can I create, a future that is better for everyone? And that starts with open conversations, being respectful, and coming into new communities. We can't treat all communities the same. We need to be individualized to each community. They have different infrastructure, different things already in place that we can kind of work with or around to help and create these new opportunities. So bringing the technology and innovation, we want to have these open conversations to be respectful and create kind of Indigenous-led, what do you guys want? We want to show you what we have, show you the awareness of the things that we can do, and then talk to the communities and say, what do you guys want? How do you want to incorporate this into your community? How can we create or transfer the knowledge to your locals and hire local people to help and kind of pull a project forward? So we're definitely looking forward to having these great conversations with all these different communities, rural Indigenous communities, and creating individualized kind of ways that we can not only work with one project, but we can use to any sort of innovation project and how we can implement these into these new communities.
No, I appreciate that. And I just kind of want to maybe just segue a little bit. We were talking about innovations and talking about accessibility, but sometimes in our rural isolated communities, there's no connectivity. They have no access to internet. So that in itself is a challenge. So if there's any IT techs out there, no, just kidding. But with that, I'm going to turn the floor over to you, Stacey, and give us some of your opening comments and thoughts on collaboration and whatever else you feel is prevalent here today.
Thank you, Colleen. It was nice to see you this morning when we walked in together. And thank you as well, Elder McGilvery, for your blessing this morning. I want to start by acknowledging that I'm from settler heritage on Treaty 6. I grew up for a long period of my initial few years close to Saddle Lake Cree Nation. And I also want to acknowledge that over the past, particularly 5 years, it's been an absolute privilege to be able to sit and be part of some very meaningful discussions, whether it was with you, Colleen, at Enoch. We've got some good relations that are continuing to be built. I also want to highlight some relationship that I've been able to build in Siksika Nation with Dr. Tyler White, and of course, grandmother Doreen Spence in Tsuut'ina Nation. And I thought I would do a couple things for my opening remarks today. One, again, acknowledge that so much of this is about taking the time to listen and learn, to be on the land. And when I had the privilege of being at Siksika, it's almost 2 years now, I had an elder come to me. She actually presented me with a pin, a beaded pin that she had worked on from Siksika, and gave that to me and said, it is very wonderful to have you here spending time and being present. And that had an impact on me that was so significant. And I actually brought that with me today. And I often carry it with me when I start to set my intentions for conversations like this. And I also want to speak just briefly. Some of you have seen maybe the bio picture that I shared for today's event. And it's myself with a wolf that I was able to be with. And I did some work with grandmother Doreen Spence using the medicine cards and was actually quite touched by her work with me on that. And it's actually the wolf that sits on my right-hand side. And so if you'll indulge me, I'll just read this briefly, not the entire descriptor, but a portion of it that really sits for me. And I'm going to put these on. And Lana, I think I am getting old, so if you'll just give me a minute. So it says, if you've drawn Wolf's card, you may be able to share your personal medicine with others. Your intuitive side may also have an answer or teaching for your personal use at this time. And as you feel Wolf coming alive within you, you may wish to share your knowledge by writing or lecturing on information that will help others better understand their uniqueness or path in life. And it is in the sharing of great truths that the consciousness of humanity will attain new heights. Wolf could also be telling you to seek out lonely places that will allow you to see your teacher within. In the aloneness of a powerful place, devoid of other humans, you may find the truth in you. Look for teachings no matter where you are. Wolf would not come to you unless you requested the appearance of the tribe's greatest teacher. And so I think that's important for today's discussion, to be a learner, but to also look for ways to be a teacher, in the sense that I'm hoping that I'm teaching and modeling the way in experiences like this, to show my humility of not knowing and asking the question and not being afraid to show that cultural humility. And so I think that that's the piece that, for me, coming to Red Deer this morning, is one that I really thought about. And again, I want to acknowledge the graciousness that has been shown by so many to allow me to have that humility. So thank you.
No, thank you as well. And I wanted to apologize to Nikawi, that's how you say mother in Cree, Nikawi Kananaskumtanan, for starting us off in a good way. Because we believe that if we create and start in a good way, it kind of removes some of those barriers that we might be faced with that we don't see. And as for the wolf, mahigan. That's how you say that in our language, mahigan. So I thank you for sharing that. And I thank the panelists here for their opening comments. I think I talked a little bit already about some of the challenges that are faced in the communities, whether it be a rural isolated community, a flying community with a winter road only, or even in our own nation where I can see the city of Edmonton from my back patio, and I kid you not. But then yet I can't get access to some of the services within my own community. So I kind of want to turn the floor over to Amanda first, and then we'll go to Stacy on how can partnerships help close those gaps in community, and yeah, let's just start there.
Okay. One of the stories that I like to tell and experiences that I have with Boehringer Ingelheim and the Pathways Project is the First Nation community of Siksika. I think I see some folks here that are working with that project, but it's a foot care project. It's a project focused on diabetes, foot care, and it has multidisciplinary partners that are involved with that team. There's the community itself, there's the health leaders within the community, but also there's New Balance shoes, and a technological company called Orpix. So all these players have come together, and basically it's an insert, a sole insert into your shoe that monitors foot care for diabetics, particularly those that have ulcers and issues with their feet. And so that's an unlikely partnership. It's unlikely that you'd have technological people coming together with Indigenous communities, with a sporting company, and government, but look at the health outcomes that are happening in this community. There's full workups being done now because the elders are happily participating with this project. They're wearing their shoes 3 to 4 hours a day. It's allowing the nurses at the nursing station to track their health, to call them in for checkups. And I keep talking and giving examples of, this is an example of innovation. This is an example of prevention. And we talked a lot about the lack of resourcing, the funding issues, but we need to change the way we think about that. And a $70 insert into a shoe versus $70,000 related to amputation costs downstream. So how do we start shifting the way we think about delivering healthcare to maximize on prevention, to maximize on community solutions and innovations? How do we bring those partnerships together? I like what was said about technology and the issues of connectivity. That is a big barrier in Manitoba. We have a lot of remote and isolated communities that are being left behind, quite frankly. And for me, I'm starting to be of the thought that connectivity and access to technology is a human right, not just for Indigenous people, but for everybody across this country, because that's just a trajectory that we're on with respect to technology, and that there's tons of opportunity to bridge the healthcare gaps by bringing technological advances to our communities. I shared an example this morning about telehealth. Originally, I had some misconceptions with telehealth in that I thought it was a bit of a Band-Aid solution, and that we should probably bring physicians to meet with people one-on-one. That kind of got turned on its head for me because my mom is like a very happy recipient of telehealth services. She loves it. She doesn't have to travel anywhere. She gets to have that one-on-one dialogue with their physician via telehealth, and she's embraced it. And so I've since changed the way I've thought and now see that there's tons of opportunity with technology to address the rural remote concerns that many of us have. So hopefully I answered something there.
I'll turn the floor over to you, Stacey, to see if you can speak a little bit about how the partnerships can help close the gaps at community.
Thank you. So I'll start by saying a couple weeks ago I was in part of a discussion where the focus was on leadership coaching. And there's a new concept now what we're working through which says, there's the idea of the big claw and the little claw. The big claw is that sort of traditional tell, be directive type of leadership coaching. The small claw is more the non-directive ask, right? Type of style. And it was funny because I was actually having a conversation with Tyler White about this, and I think where that resonated for me was we can learn from Indigenous communities about actually how to have that non-directive conversation to get good outcomes. And we've often been at the table together, Tyler and myself, where there's been that sense of urgency to do something. And every time he'll come to me and say, Stacey, just listen. Just listen. Reflect, inquire, pause, have action. And I think from a collaborative perspective, we've seen on a number of occasions, whether it's been having conversation at Enoch about how do we have those cultural sensitivity conversations, cultural safety conversations, whether it's going into Siksika Nation, spending almost 2 years developing a memorandum of understanding to recognize the right of the First Nation to have that self-governance in healthcare while also recognizing and receiving the privilege from Siksika Nation to be able to regulate physicians on the nation. This takes time. Trust is built over time. It's broken within seconds. And so from a collaborative partnership perspective, I really value being able to walk alongside a number of Indigenous leaders that consistently share with me that same message on the little claw of asking the question, being non-directive.
No, thank you so much for that. I just wanted to say, mention in respect to my Treaty 7 brother, Tyler White, if any of you talk to him, let him know that Oilers won last night. And it was a good one. So all joking aside, I am going to kind of turn the floor back to you, Amanda. If you could talk a little bit about the Pathways project, and then we'll move on to you, Cassandra, on a different...
Okay, so as previously mentioned, I've had the privilege and the fortunate pleasure of being involved with Pathways through Boehringer Ingelheim. Basically, Pathways is a group of Indigenous health professionals from across the country, and we were engaged by Boehringer Ingelheim to help them develop a framework to guide discussions on how to develop respectful relationships, relationships based and grounded on reciprocity, so that it wasn't just a one-sided relationship of them funding us and then taking information and so forth. And so we built in safeguards like OCAP principles so that First Nations safety was at the forefront of our efforts in terms of ensuring that any data derived from any of these projects would be owned by the community, they'd be controlled by the community, accessible to the community, and in possession of the community. And there is a big movement right now happening across the Indigenous country with respect to data sovereignty. Our people have always been natural storytellers that have carried on, history through our stories and our legends and through ceremony. But now I think we're seeing the importance of formalizing and capturing that information through data collection. The data collection is allowing us to create appropriate interventions based on our interpretation of the data. So Pathways really elevates the self-determination of communities to determine solutions and outcomes based on their desires, based on what's happening at the community level. It's been a great project, but like I said, I see that the need is so much greater than just one philanthropic company. Like I said, we had over 30 different innovation projects come to us from across the country, and we were limited to selecting 4. So I know that there's other industry partners that would be very well suited to accommodate and create partnerships with those First Nation communities to address health outcomes, but to also encourage innovation, to encourage our people to really dive into that technological sphere. But one of the messages I think that needs to be brought home is that innovation can only happen with evolution. So these evolution of relationships are important. The evolution of the way we think of funding healthcare has to change. The evolution of how Indigenous communities are funded right now is just based on programs and services and nursing station models. And it doesn't leave a lot of room for innovation. And so a message here to the change makers and the government officials or people that have some influence in that sphere, it's time to open up this conversation and make that space for Indigenous people to lead the innovation, and in collaboration with people from outside health sector. I think this has got to be beyond health to address social determinants of health, and that there are calls to action right now from the Truth and Reconciliation Commission that do have very specific, actionable items that can be implemented. And it's a responsibility of everybody to be aware of that. And how can you take those calls to action back to your organization, your departments, your ministry to really put some concrete demonstration behind that to meet Indigenous people, because we're willing to be partners. We're tired of the rhetoric of resilience. We're tired of being resilient. Now we want to go forward with you as an equal partner to solve the healthcare crisis that's not just affecting Indigenous people, but everybody in this country. So, miigwech.
Tapwe, hi. And I just want to maybe say that the word reconciliation, and then it turned kind of into reconciliation. But then I say, you can't reconcile what you don't recognize. So that to me hits home. And talk about the data sovereignty piece in just a little bit, and then I'll segue over to you, Cassandra. For many years, we've been researched and studied, and whether it be through the different avenues, and we did a research project with the University of Alberta with our young mothers, and the findings were a little bit disheartening. We had a crisis in our community. And when the publication was published, it created a negative connotation of our community. And such remarks as they belittled our women. They talked negatively about the findings in the publication, so that data and the OCAP principles are critical. Ownership, control, access, and possession. And that is our data sovereignty. So thank you for a gentle reminder on that. So Cassandra, I'd like to turn the floor a little bit over to you, and if you maybe can talk about what other innovation projects have been tried and that can improve access in Indigenous communities, and maybe then segue into the hip dysplasia.
Perfect.
Yeah.
Yeah, so one project that we're specifically looking to go into Indigenous communities is universal screening for developmental hip dysplasia. So some babies are born with just immature hips, and being able to catch that in a good amount of time and treat that very early on goes into the prevention aspect of a lot of things. So preventing arthritis, preventing a lower quality of life, preventing the need to go to opioids, other pain medication because of this hip problem. So being able to kind of give these infants the best hip forward, the best step forward that they can to, go on with their life. So what we've created is, and I guess one thing I should say is why we want to go into Indigenous communities is we have studied that it's about 30 times more prevalent in Indigenous communities than a general population. So unknown reasons why could be genetics, could be kind of some environmental factors, but we really want to target these communities because of such a high incidence. And so what we've created is portable ultrasound, which is the best way of looking at hips, with artificial intelligence that we can equip locals. We want to train and transfer the knowledge of this screening to the locals so they can continue to screen their infants within their community and not have to travel to Edmonton or Calgary to get the screening for their kid to be normal or for them to have to travel weekly for appointments. So we want to be able to equip and transfer the knowledge to the community of being able to have that healthcare equity in the community. But in order to do that, we need to have these conversations and learn from the community as well as to when we can do that, where is the best place to do it, to work along the infrastructure that they already have and create them to have the most successful and longevity and sustain this project past the research part. And we specifically use these OCAP principles when going into Indigenous communities to carefully cultivate these research agreements so they know that we are being respectful with this information. We are doing it to help and kind of, create a longevity for their healthcare equity in their communities. So along with that project, we can use the framework that we have been implementing into these communities to help with other implementations of other innovation projects. So whether that be, medical imaging or any sort of innovation that wants to go into these communities, we kind of have set the groundwork, set the framework on how to do this, respectfully and approach a community with the idea that we want to tailor it to your community, to tailor to what you need and not just tell you what you can have and tell you what you need. We want to have this open conversation and work together to create this longevity and successful project and then, to open the door to any other innovation and project that can come as well.
That sounds really exciting. And I think that what makes sense if that early diagnosis and if that can be done early on, it's going to be a lot easier on the pocketbook of the government. I'll just say it like that.
Yeah, it definitely helps cost effective and, quality of life as well.
Absolutely, for sure. And I'm just wondering, all joking aside, I might be one of those babies because my hip is now hurting. Just talking about it. But no, thank you for that so much. So I also want to, aside from access and other major barriers, we experience is cultural safety. And I'm just going to share a little story with you that I shared with the team the other day. We did a research project once again with the University of Alberta, and it was with our young moms. And one of the things that was really disheartening for me is this young lady was, I believe, on her second or third child. And she went into a clinic late second semester, early third semester, around there for the first time. And when she walked through the door, the MOA, or the medical assistant, treated her very disrespectfully and said to her, kind of shocking, like you're just walking through the door now and you're heading into your third trimester, and belittled her. And she told that lady, it's because of people like you that keep me from walking through the door. So there's this systemic racism that we experience, and I'm just going to say it, and it's true, and it's proven, and we know. And we need to get better at it. And it was just really a sad story to think that this young lady was afraid to go to the clinic for fear of being judged. And as the trimester went on, once again, her fear even grew further. And another personal story that I'll share about some of the systemic racisms that we face in the cultural spaces that shouldn't just be reading a module and checking off the box, we want to partner with the colleges and the universities to change that curriculum to really impact what does cultural competency really mean. And most recently, we had a young lady in the hospital who was given some traditional medicines to help her. And it went to ceremony. So we're on the hook, they're on the hook spiritually. Protocol was offered, and that medicines was brought to this young lady in the hospital to drink. And they got told, if I can't read what's on the label of the medicine, you can't give it to this individual. And so that in itself to me was a little bit shocking. But I also know that there was a policy that was placed through AHS that Indigenous people have rights and access to their medicines while in the hospitals. So we got to get better at educating our partnerships, the nurses, the staff, and the administrators as well. So having said that, mentioning again, you can't reconcile what you don't recognize. Question to Amanda and Stacy in no particular order. How can we get better at working together to create those safer spaces?
So I'm a big champion of anti-Indigenous racism work in my day job. My team has actually created it's called Disrupting Anti-Indigenous Racism Training. And it's similar to cultural competency training, although I really struggle with that language because as you said, I'm not sure how competent anybody could be after a 1-hour course checking off boxes. And so our training focuses more on the conversations and dialogues. There's not a grade, there's nothing to pass. And our training is actually not about what you know about Indigenous people, but rather what you don't know. And it's more of a self-reflective tool that we use instead of, we're going to teach you about Indigenous people. No, we're going to teach you how you think about Indigenous people, how your perceptions were formed about Indigenous people, and how to potentially undo or unlearn that work. And so we're quite proud of that work. There's a lot of governmental folks, healthcare practitioners that are at the door waiting to take this training. But I think it has to go farther than that, because what we recognize is that it's great that we're creating a woke group of people that can now point out anti-racism, racist actions as they happen, but where do they take them? You know, what are the systems and mechanisms that exist in the healthcare settings that allow for people to report incidences of racism? So I've experienced it quite often, actually. I delay treatment for myself for these very issues of being judged, being targeted or misdiagnosed as an alcoholic or a drug user. Like, those are the questions that come at Indigenous people first and foremost, and so it can be very off-putting. And so how do we create the mechanisms to report incidents of racism? To resolve that, is there, like, we're doing an examination in Manitoba right now to look at what institutions are doing to really actively address anti-racism. Do you have a mechanism for reporting anti-racist or racist actions between staff and patients, and how do you resolve these issues? One tool that I learned, I went to a conference in Quebec once, and I ended up in the wrong room, but I'm so grateful that I did, because it was a room full of transgendered youth, and they were talking about healthcare that they've received in the province. And what they did is they created a map of the province, of the different provincial healthcare systems and entities, and they gave those entities marks. So 3 stars, 5 stars for feeling completely safe, 1 star where I felt really abused and not treated appropriately. And that really, I think, shone a light and gave people the chance to see the experiences of that population, and I think there's value in duplicating that type of an exercise for our Indigenous people in Manitoba. So these are the types of things that we're exploring, but again, it takes a willingness and commitment from everybody in this room to want to do this work, to want to support this work. It's great that it's Indigenous led, but we need those partners to make it viable and sustainable.
No, No, really, thank you for that. And I just want to add before I go over to that, that it's not just Indigenous, it's marginalized populations. So I want to kind of stress that as well. And but I think we really need to get better at it. I keep saying that over and over again. And I'll turn the floor over to you, my dear.
Thank you. So I have a counselor colleague, Dr. Nicole Cardinal, who talks to me often about get comfortable being uncomfortable. And, I think around cultural safety, there is opportunity for us to use a TED model where we sit together, we ask them to tell the story, explain this to me, describe how this felt. And it's intentional, right? It's intentional to be able to spend time to use that model to ask those questions, but it's okay to start being comfortable being uncomfortable. And I think the sensitivity for Dr. Cardinal and I is even more so evident because I know that her family and my family lived essentially beside each other growing up. And I shared a story with her that, resonates with me. And even though I was 6 years old, having my family say to me in St. Paul, if you're facing an Indigenous person, right, walk on the other side of the street. That was me being comfortable, being uncomfortable, sharing that story with Dr. Cardinal, knowing that her family, it could have been her family that was coming towards my family, and it was my family having that reaction. So I think when it comes to cultural safety, if I can leave the message of being comfortable, being uncomfortable, is one that, for me resonates, and I try to practice every day.
No, I appreciate that. And I think, I know I'm the one saying I gotta go, but, and I was joking yesterday in the call, or I was like, if I have to do a working lunch, I will. If the conversation is flowing, I will not stop it. But here I go, right? Stopping it soon. But another situation, I just want to share something with you. I wasn't born a blonde. I pay for this. But it was a couple years ago, I had a shoulder injury, so I was in a sling. And I had an anaphylactic reaction to shrimp. Never before in my life. I still love it, but I can't eat it now. I'm too scared. And my throat started to swell, and my eyes, I started feeling itchy, and then my tongue was itchy, and my lips felt weird. And it happened to be Mother's Day. And I said, I am on strike today. I'm ordering in. I'm not cooking. I'm not doing no dishes. And it was just my husband, who's in a wheelchair and does not drive. And our young child, who's only 15, does not drive. And my son was at work. He happened to get home early for work on a Sunday. They sent him home early for work. Thank God, because I was going into anaphylactic shock. The ambulance couldn't find me, but Uber Eats found me that day. But the ambulance got lost, couldn't find my house. So I told my son, you have to bring me to the hospital. By the time I got there, I couldn't speak. My eyes were closed shut. My ears looked like cauliflower. He said I looked like a tomato. And I went, literally, he pulled up to the emergency doors, and I just had enough in my vision. I knew which doors I had to get to. And I walked in staggering, slurring, eyes swollen shut, shoulder sling. I got told to wait my turn. Oh, let me get angry so I don't get upset. And if it wasn't for my son, he just came yelling, my mom is having an anaphylactic reaction to shrimp. And I don't even really remember what happened after that. But I was profiled right then and there. And then as I started coming to, there was a fella beside me, and I could hear them say, how much did you have to drink today? How much alcohol did you drink today? Then I could hear this lady down the hall saying, you guys are treating me poorly and just because I'm First Nations. And I thought, why, Creator, am I hearing all this? What's the reasoning? But I know that there's much work to be done. And I'm just one story out of probably tens of thousands. So in gentleness, and I'm not trying to make, maybe I am trying to make you uncomfortable. I don't know, am I? But it's not deliberate because I come from love and I come from the commitment to work together, and I know we all do here today. So with that, it's saying that, I'm getting my flashcard here again. We talked about cultural safety. You gave us your perspectives. Thank you for that. But I think everyone here acknowledges that it's important for the projects and change to be Indigenous-led. Like I said, nothing for us without us. So what I'm going to do here, and give you each a minute, I probably took most of the time here, just give us some closing thoughts that you have that might be you missed, that you wanted to say and didn't get a chance to. And I will start with the young lady in the middle this time.
Sure. So I guess, yeah, kind of a theme, you just having that open conversation and that two-way transfer of knowledge. One of my favorite things about medicine is you never stop learning. And you never feel like you're at the top of your game because there's always something to learn and always something new coming to the field. So, I mean, using that in your everyday life and going into these communities with that, openness and open heart, open mind that I am going to learn from everyone in this community. I also want to teach them. So this two-way transfer of knowledge is so important that we just do it the right way, do it respectfully, appropriate, and if I don't know, I need to ask, and I need to be comfortable with not knowing something and going to the experts, the community experts, to ask them and to teach me so I can learn and use that for my next experience.
Thank you. Our friend on the end.
Thank you. I'm just going to close. First and foremost, I want to thank Health Cities for actually identifying and bringing this forward as a panel discussion today. Every opportunity I get to speak to this with good partners, with good collaborators, with good colleagues, I will take that opportunity every day. Cultural sensitivity, cultural awareness, cultural humility, it can be overwhelming. Where do I start? And I think it's important to know from someone who asks that question that it's welcoming, that it's welcome. That question is welcomed. So is the question of, I don't know. Right? It's that first step. And I think the last thing I'll leave is this art, and I will use the word art of storytelling, is more powerful in the practice of healthcare, and particularly the practice of medicine. And I think we can all learn from that art in ourselves to be reflective, but also how we care for each other. And I appreciate the opportunity like this today to be able to be part of that story. So thank you.
So many great comments today. I'm taking a lot home as well. Maybe the kind of final thoughts that I can leave you all with is we did an extensive engagement project in Manitoba with our Indigenous population asking what drives positive health outcomes, and the number one answer was focused on prevention. So stopping health issues in their tracks, bringing healthy nutrition back to communities, resetting the strengths in our communities, resetting that place of taking care of ourselves. I think there's been a bit of a dependency that was created due to the way our communities are structured and provided some funding, and we're looking to shift that. I think it's got to be acknowledged that there's a long history of colonization in this country, well over 100 years. My mom is 76, and she is a product of the residential school system. I'm not that old. Well, I guess I'm getting there, but it's relative recent history that needs to be undone, and it's over 100 years of disrupting, Indigenous ways of life and knowing and being, and so it's going to take some substantive investment to undo that work, and so there has to be appropriate investment into the infrastructure, talking about the way things are changing. Our young people need to be engaged. Our young people are so hungry for technology. They're so hungry to create solutions at the local community level, and they're the group that I always go to first to engage with, because they're not maybe jaded, I guess, the way maybe we are at this stage in life. And man, it's phenomenal what they have. And so there's a need for all of us to cultivate that within our Indigenous communities, because I think they're going to bring forth the answers not just for Indigenous health, but for healthcare, a healthcare landscape for all Canadians, and so that it's a place that we all can thrive.
No, thank you for those closing comments. And with that, I hope we're not just here today to plan. And I hope today that what is documented in the records and the notes does not just sit on the desk and collect dust. And I hear the word often, and maybe this is a gentle education piece for me personally, talk about our knowledge keepers. I want to change the narrative, and I want to say there are knowledge teachers, because we're losing our elders. And they are taking that, they're taking that knowledge with them. So these are our knowledge teachers, and we need to create spaces for them. And thank you for acknowledging the youth, because I was going to bring a youth with me here today, because I'm very passionate about youth and the mental health sector of our youth, who eventually turn into, they age out, and then they fall through the cracks in some cases. So if there's anybody in the room that wants to have a conversation on that, I hold that mental health piece dear to my heart for various reasons. And we need to also create that space for our youth to be in the conversation, because they'll tell us that we don't have a clue. We don't have a clue. And with that, I want to thank the panel before us, current panel here, and the ones to come. Hi, gananaskumtanan.
I wanted to welcome our Health Cities CEO, Reg Joseph, to the stage. He's going to join our presenting sponsor, which is the Arthritis Society of Canada, on stage for a Fireside Chat. Please welcome Joanne DiNardo, Senior Director, Public Policy and Government Affairs, and Stephen Weiss from the Board of Directors of the Arthritis Society of Canada. Rumor has it, that maybe they have some prizes to give away, but I believe they have to be earned. So pay attention, and again, please continue to enjoy your lunch and welcome them on stage. Thank you.
Test. I think there's some questions showing up. That we have a little trivia for all of you, and that was thank you for that lovely introduction. I'm Joanne, and you'll see there's 3 questions. So we're going to say the first two. Question number 1. If somebody knows the answer to that, first table to yell it out gets a prize. You said. What did you say? Oh, true. Who said true first? Hands up. Did you see? Okay. I can't see the question from here. Yeah. And who said true first? Who's going to put up their hand? All right, let's pick out a table. Was it table over there? All right, let's do it. You did it. So yes, there are more women than men that are affected by arthritis. 1 in 4 in Canada versus 1 in 6 men. Just so I can see. I think the second one is about the hip dysplasia. Oh, damn. Yeah, I think it's that same table.
If you're a competitor, you can't win.
Okay. And third question related to childhood arthritis. Do we know how many it affects in Canada? Any other table with an answer? Hey, let's go here.
There we go. There we go.
Thanks so much.
You should ask what you win.
Cheryl, stare at you.
Yeah, sure. Well, I'll kind of move the chair over a little bit too. There we go. Are we on? Good. Okay. Well, thank you, everyone, and please continue eating as we're going to talk a little bit about the Arthritis Society. Joanne and Stephen, so glad to have you here, and glad you're able to join us today. We'd like to learn more about the Arthritis Society. So, first of all, given from the conversations earlier today, we've been talking about challenges and opportunities, innovation. One of the key things that we talked about, though, is who needs to be at the table. And we've got a pretty good diverse group here, but maybe we're missing people. So, Joanne, your thoughts in terms of who else needs to be at this table?
Great, thanks for the question. We talked a lot about marginalized communities, specialized communities where we need to pay a lot more attention to, and we haven't been over time. And within those communities are people, and many of those people are patients. And it's the patients who really need to be at the table. This is the role that we represent at Arthritis Society Canada. It's one that we've put a lot of time and energy into in ensuring that we can give the patients a voice. And I would say even through, in my role as an advocate, leader, teacher, I'm in a job shared role. I have a partner in my role. The two of us really have come to the Arthritis Society wanting to enable patients. And in doing that, we've developed a volunteer team that are advocates. We have many people who are willing to help us volunteer and put our message out there. But the team, we've created a specific in advocacy so that they could feel like they can go forward equipped with all the resources and knowledge and be that voice at the table when we're making health system changes across the country. So patients would be my simple answer to that.
Perfect. Wonderful, that's great. So on the innovation side, and we talked a little bit earlier today about partnerships and industry with government, with healthcare providers. I have had the opportunity, not only with the Arthritis Society, but others in the philanthropic sector that are making moves in terms of innovation and healthcare. And can you talk a little bit about the role of philanthropic organizations in this space?
Sure, I can talk from my perspective first, and Stephen, if you want to jump in. So as a philanthropic organization, a charity, we have an opportunity to use our donor dollars wisely, and those dollars really help us come at a problem from a nonpartisan angle, from a needs angle, from an awareness, from a partnership angle. We've embarked on this incredible journey now that our CEO is taking us on, which is developing an arthritis action plan in the country. This action plan is going to be the embodiment of the entire arthritis ecosystem. Everybody, all of us, hand in hand, as much as possible. Of course, there's going to be, disagreements. We're not always going to be hand in hand, but it's really about being that one voice as a collective, and to do right by the people who believe in us to do right by them. So it's really about enabling us to transfer knowledge, to educate the public, to develop materials, to take our requests to government as a collective and responsibly apply that to system change that impacts each patient in a way that we can deliver good health care, but in communities. That's the other piece of being a charitable organization. We're able to be a little bit of everywhere. So some charities we see, we change, we evolve. Some of us used to have offices everywhere, and then we centralize, and then we look at that model and we say, okay, was that the best model? Okay, let's decentralize. Well, let's centralize, but with a focus on community. Let's not forget about the communities. And that's something I think we've done really well in terms of ensuring that we can still have place in the community in terms of delivering our services there.
I think that's a very good way to put it. The other thing about the Arthritis Society, pardon me, is that it's got multiple pillars. And it's involved not only in advocacy and education, but it's involved in supporting research. And the CEO has done a remarkable job with support from people like Joanne to develop an innovation strategy as well. It's looking very, very closely at a number of different environments where innovation is important, and it has a certain kind of, let me call it social responsibility, to drive innovation by supporting it. It's not just financial support, but awareness as well. And if the society can consolidate, that is to say, sort of represent the eco-arthritis system or around this country, there's a great opportunity to spread that kind of wealth and support the kinds of studies and programs that are so prevalent today. I mean, I couldn't help recognize the comments by the first panel about how much innovation there is, and yet the inability to drive it home is so difficult, and that's part of what the Arthritis Society of Canada wants to do, if it can. That's really an important aspect of it as well.
Wonderful. Thank you both for that. Stephen, I'm going to pick on you a little bit. You and I just met last week, and we realized that we have a lot of connections in common, including our dear friend and my mentor, Cy Frank. Stephen, your background was so interesting when you and I chatted, and I'd like to get into that a little bit more about your background, but then more importantly, how did that drive you to the Arthritis Society?
That's a good question. I ask myself that all the time, but it's actually an easy question for me to answer. I've been on the board of directors of the Arthritis Society of Canada for about 4 years. And the transition for me has been relatively simple because the values of the society align with my values and the work that I've done in the past. I moved to Alberta about 15 years ago, and I went to work for the Alberta Bone and Joint Health Institute. Some of you know it. It still exists. I see heads nodding. Thank you. In any case, I worked closely with Cy Frank. Reg just mentioned him. He was a prominent researcher, orthopedic surgeon, and also a health policy game changer. Before he died, he was the CEO of Alberta Innovates. And he was really moving and pushing the kinds of changes that we've been talking about here today. Really a very innovative guy, and I learned a heck of a lot from him, especially as it relates to arthritis and approaches that one takes to try to tackle a massive problem like arthritis. You can see the statistics on the blackboard, and they're enormous. I mean, the numbers of cases. Well, the Institute collects a vast amount of information, and that information is shared readily in this province, both by patients, by healthcare professionals, particularly with respect to continuous improvement, shared research, shared data. That's very important. The information is also provided to the government, and the government can use that information to determine, is it using its resources in an appropriate way? Are they utilizing the kinds of valuable, scarce resources we have? I think that's important, and that's the kind of work that this institute does and has been doing. What's valuable for me, in fact, has been that is something I've cherished, I valued. I never worked in the nonprofit area before until I went to work for this institute. I always worked in the for-profit sector. But Cy recognized the combination of both the non-for-profit and for-profit sectors. And that was mentioned as well by one of the panels, and I can't remember the person who said it, but she is correct. And my point is that those values link and align very closely with what the society is trying to do. So it was easy for me to go into that role because that's what the society is embracing and trying to do.
Wonderful. Thanks, Stephen. Innovation. We've heard a lot of that word thrown about today. One of the things I want to pick up on innovation, Jody mentioned it, Amanda mentioned it, that it's already here. This is not something that's out in the future. We're living it. We have clinicians that are practicing it today. Cassandra mentioned in the last panel a little bit about the project that she's been working on as a physician. It's a two-part question for both of you, which is talk a little bit about that project and where do you see Arthritis Society wants to go with that in the future. But more importantly, I think what's interesting here is that that's not a model just for arthritis. It speaks beyond a single indication. And I was wondering if you wouldn't mind tapping into that piece as well.
Great, yeah. It answers the lack of innovation or the need for innovation is a call, it's a cry. We did a State of Arthritis in Canada report card we released in October. That report card showed the highest grade. We graded the entire country on access to treatment and care, wellness, and research and innovation, with the limited data that we have available. And so we used where we could find publicly available data to assess all of those. The highest mark across the country, mark of C, grade of C. Alberta, Quebec, BC, Ontario, highest grade. That's a problem. We're not here to just talk about problems. We're here to talk about how can we innovate? How can we have solutions? And so we need to start thinking about solutions-based projects like the DDH screening for infants. That program is one that we are so excited about, excited to work with Health Cities on that piece, and excited to move that forward in a grander scale when we recognize how much impact it will have on just specific populations, at-risk populations, but beyond that in terms of alleviating burdens on the healthcare system. Other innovations that we've found successful at Arthritis Society have been, I spoke to community earlier, but things like advanced care practitioners in arthritis care, people who are trained specifically to understand how to address arthritis. We had our wonderful speaker talk about prevention. Prevention, in terms of having community programs, prevention is the goal. We don't want to see everybody lined up for joint replacements, especially knowing that the wait times are increasing. If we can prevent and have appropriate people present to orthopedic surgeons for joint replacements, we can have the appropriate people present to rheumatologists. So we can use these advanced care practitioners not only in orthopedics, we can also apply them in rheumatology. We've actually put a proposal forward to the Ontario government to do just that in Ontario. There is a pilot program, but there are also other programs, and that would help us expand to work in collaboration with primary care and the community. So you have advanced care practitioners, they're occupational therapists, they're physiotherapists. They can work on joint management strategies. They can work on rheumatology-related strategies to manage conditions before people get worse, before we have to burden the system.
Yeah, I agree with you completely. I'm going to take a different tack here because I think you've covered that the waterfront there very nicely. I thought that the first panel really hit on something very interesting. There's plenty of great ideas, but it's about the implementation and the sustainability of those programs. That is really tough. And it seems to be a Canada-wide problem, but to your comment earlier, it's a worldwide problem. It's very tough to change culture and so forth. But over and above that, I think that innovation really is critical, and that's one of the themes of this meeting today. But innovation is only useful if it can be cost-effective, if it can improve quality of life, and it meets an unmet need. which very frequently is not the case. Sometimes I've seen things where it's a test in search of a disease. Terrific. That's just what we need. A lot of energy and not much for it. So if we can meet an unmet need, understand what that is, get to the root cause, develop that technology, but equally importantly, understand the cultural needs of the patients in question. That's what I loved about what the second panel had to say. I think that we are a long way to getting to where we need to be. That's really the point here. And that's certainly true with the work that Dr. Jaremko and Dr. Gallant are working on today with respect to hip dysplasia. So, thanks.
And just to pick up a little bit more on that is the connection. Not only is it in arthritis programs, or might have innovation in arthritis, but that innovation, just like you said, Reg, it can be translated to other chronic diseases. It can be applied across the spectrum. When we are talking about community care that triages patient so that we have the appropriate level of care at the appropriate time for the appropriate patient, that can be utilized in any disease sector. So it's really establishing those pathways and those systems ahead of people presenting to the clinicians and specialists.
Wonderful. I'm going to throw another buzzword at you, and we heard a lot about this morning. Funding. We heard about lack of funding. We need more funding. We talked about pragmatic use of funding and making sure the funds go where they need to be. I'm going to take a slightly different tack here. And as we talk about adoption of innovation, driving outcomes, Richard talked about this as well, in the community, what else besides funding do we need to make that happen?
You want me to answer it? I'll start.
Sure.
All right. I'll try to answer it at least. It's really about awareness. It's really about making sure that people understand why something should be applied, should be utilized. It needs to have a value proposition associated with it. Too often, something is done, very good research is done all over this country, certainly in arthritis and many other areas, but very frequently it is not implemented because no one knows how to message it properly. Some people call it knowledge mobilization, knowledge translation. Whatever you want to call it, it needs to be addressed, and it needs to be addressed in a very plain and obvious way to people so that health systems across the country and patients speak out about it so that it becomes an important sort of way of moving things forward. Very frequently, I'll give you a good example. Hip and knee replacements, the wait times are horrific in this country. People are frustrated by it. But it isn't just about more surgeons, more operating room time. Does Alberta have more money to do 3,000 more cases? I'm not sure if it does, and I'm not sure if it should do that, given where we are today. Maybe there are other approaches that need to be taken. Perhaps some of those patients should undergo, let's say, a more conservative approach, at least initially, to see if that helps us. We need to break away from the pattern of always saying, all we need is more money and it will be fine. It's not true. It won't happen that way. So I think that's an approach that we need to take. It's not just about money. It's about awareness, and it's about being open to ideas and approaches, and that's where innovation potentially has real advantages.
And also, to add to your great response, is the ability to partner with governments on public awareness. As third parties, charitable organizations are a very good place to place the role of public education and public awareness. And we can do that well. As Stephen said, we have excellent research going on. We have excellent programs happening. I heard things today some things I didn't know, and I thought, this is amazing. Like, why don't we know about this? So this is the role that charities can play, and patient organizations can play, and our patient advocates. So we have a body of patients that are just eager to get out there and talk about their experience, their stories. And we love when they share their stories because they bring they bring the change, they drive the change, because it's due to them speaking to an elected official who's in office for 4 years, and then they have to go do it all over again, and maybe in a little bit different way. But that's their role, is just reminding people why we are trying to have the best care health system, why we're trying to have the best quality of life for patients, and really having their voice at the table, and having them be our patient voice in everything we do when we're designing system change is absolutely paramount.
It's wonderful. So Joanne and Stephen, I want to thank you both for your leadership, your support, and more importantly, for being here today. Thank you.
Thank you for having us too.
How's everyone doing? How was lunch? Good? Seeing some nods, yay. That's great. Thank you to our previous panelists. Now for our grand finale panel. I'm very excited about it. The topic is navigating opportunities in women's health. Now, this session aims to shed light on the distinctive challenges and opportunities that arise in addressing women's health within primary care settings, from promoting preventative care to tackling gender disparities in healthcare. Our expert panel will share insights and strategies to enhance access, quality, and inclusivity in women's healthcare. Our moderator today is Sandra Stable, Director of Digital Health at the Heart and Stroke. Sandra is passionate about harnessing innovation and technology to tackle complex health challenges, including inequities in women's heart and brain health. Beyond her role at Heart and Stroke, Sandra actively contributes to the innovation ecosystem. Sandra is also an investor with Startup TNT, an angel investment group, where she supports entrepreneurial opportunities and fosters the growth of promising health sector ventures. Dedicated to breaking down gender barriers and fostering inclusivity for her mother, sisters, daughters, and all those who identify as women. Sandra believes that when women reach their full potential, we will shape a better future for all. For our panelists, we have Carmen Whiten, founder and chair of the Women's Health Coalition of Canada, principal at Ripple Enterprises. Carmen has more than 25 years experience working with nonprofit organizations, government advisory councils, charities, and industry associations in multiple areas of the private and public sector. In addition to Women's Health Coalition, Carmen is an appointed member of the Alberta College of Pharmacy and on the executive of Public Affairs Association of Canada. As a primary consultant with Ripple Enterprises, she is currently serving private sector and nonprofit clients in health, kid and youth sports, community foundations, and industrial associations. Next, we have Dr. Colleen Norris. She has so many acronyms and cool titles, but I'm going to keep it to the top ones, which is Professor and Associate Dean of Research, Faculty of Nursing at the University of Alberta, and the Kaverzan Chair in Matures Women Health Research, Faculty of Medicine at U of A as well. Dr. Norris, a nurse by training, is the past chair of the Canadian Women's Heart Health Alliance, Health Policy and Services Working Group, whose mandate is to implement policies that advance our understanding of the unique sex and gender factors affecting the outcomes of women's heart health. She is the co-lead of the Women's Heart Health Atlas, which is curated as an open access chapter on the Canadian Journal of Cardiology. Dr. Norris is a fellow with several organizations evaluating the impact of sex and gender factors on outcomes. Dr. Norris has presented extensively and has over 400 publications in the areas of sex and gender differences in cardiovascular treatment and outcomes and women's heart health. Lastly, we have Danica Kelly, CEO and co-founder of a local health tech startup called Minorbitive. Danica Kelly is a health and wellness professional and trained socio-cultural scholar in issues around female health and representation. For the past 14 years, she's worked globally, focusing on health advancement and knowledge translation in developing economies. Danica has a strong history of leadership excellence in the social innovation space, winning awards and recognitions from TELUS and the Future of Good, DMZ Woman of the Year, Femtech Analytics, Femtech Focus, Alberta Women Entrepreneurs, and more. Danica acts as an advisor on sex and gender equity to the Commonwealth Business Women Network and the United Nations Office of Outer Space. And I have to also say that she also does this kind of advice and is working collaboratively with my charity, the Branch Out Neurological Foundation. Really excited for this panel. Please welcome our speakers on stage.
Pretty powerhouse lineup of ladies, if I do say so myself. I want you to imagine if we only tested prostate cancer drugs on female cell samples, or encouraged only men to check their blood pressure. Does that make sense? I'd like to begin by asking you all one question. Do we truly value women's health? It's been said that every cell is sexed and that every person is gendered. This underscores the importance of recognizing the unique and diverse health needs that exist between sexes and genders. So just to set the stage for today, gender, on one hand, is socially constructed. Those are the roles, the behaviors, the expressions, and the identities that people live with. Sex, on the other hand, is biological. Those are our physical features, our chromosomes, our gene expressions, our hormones, and our anatomy. Both impact our health much more profoundly than I think we ever knew until recently. Women's health is defined as the health conditions that affect women uniquely, so things like endometriosis and menopause, but also conditions that affect women differently or disproportionately, like heart disease, pain, certain types of cancers, and Alzheimer's. While maternal and infant mortality is the global benchmark for community health and for systems performance, the total burden of women's health is completely understated. We tend to underreport the burden of sexual and reproductive disease because we don't have the data. And then we completely dismiss the conditions that affect women differently and disproportionately because we don't have the data. We've all heard the old adage, what gets measured gets managed. But first we have to name the problem before we can solve it. So our stats are incomplete, to say the least, but we can begin to scratch the surface. So consider this. Close to 750,000 Canadians are living with Alzheimer's. She represents 75% of them. When she is experiencing symptoms of a heart attack, over 50% of the time, it will go unrecognized and undiagnosed. Later, she's more likely than he is to have a second heart attack within the year. After she experiences a stroke, she's 60% less likely to regain independence within her daily activities than he is. If she happens to have a uterus, she has a 1 in 10 chance of having endometriosis and will wait an average of 5 years to be diagnosed. 75% of adverse drug reactions happen to her. She represents 70% of patients with medically unexplained symptoms, the cornerstone diagnosis of anything related to infertility and lady bits. Anyone who's gone through infertility has gotten this unexplained diagnosis. Although she will live longer, she will live more years in poor health, affecting her ability to be present, productive in the workforce and the community, and reducing her earning potential. She is continually misunderstood, misrepresented, and misdiagnosed in our health system. And due to the gender norms and roles, she also performs 1.5 times more unpaid labor than he will. And when the formal healthcare system fails, she will disproportionately bear the burden. If she happens to live in a rural setting or come from an Indigenous population, these challenges are even further amplified. Despite these staggering statistics, which I told you at the beginning are just scratching the surface, only 7% of national health research goes to women's health research. She is suffering in silence, facing barriers to care, diagnostic delays, and suboptimal treatment. The health gap persists in science, in data, in care delivery, and in investment. It's crucial to recognize that half the health burden on women occurs during their working years, which has a profound impact on the economy. So I ask you again, do we truly value the health of women? Today, our panel, now that we've set the stage with the burden and what the challenge is, we're gonna spend most of this panel talking about solutions. We wanna delve into some myths, some inequities, and we wanna talk about actionable solutions and innovations to address these challenges. So let's begin our discussion on how to ensure her health is prioritized, understood, and adequately addressed. All right. Okay, so we're going to start with some myth busting. In our prep call, there's so many myths, and I'm sure that some of the statistics that I just shared maybe were surprising to some of you, but there's even more surprising information out there. So I'd love to kind of do a round of myth busting with each of our panelists, just stating what you think is sort of the most profound myth that needs to be debunked. And I'll start with you, Danica.
Great. Hi, everybody. I will start in advance. Can you hear me? Ooh. Test. 1, 2, 1, 2. We're good? Okay, I will also apologize for my voice. It turns out at 5 months pregnant, 6 cities in 10 days is too many cities in 10 days. So please excuse the raspiness. First of all, Sandra, that was an amazing introduction. I think you did a ton of myth busting just in that introductory statement. And I think that the space that I was going to lean into was around that idea that males are adequate proxies for females, or that men are adequate proxies for women. And I think that one of the most interesting spaces in which we see that bias alive and well today is in our ethics application process in the research world. So the two most common reasons for the exclusion of female identifying and women presenting persons in clinical and observational studies is one, that males are completely adequate in this particular instance to be proxies for females. And the number two, which just blows my mind, is that women are too complicated and female hormones are too complicated, and so we couldn't possibly be asked to capture all of that in our study. And to me, those two fundamental reasons directly oppose each other and blow my mind that they're still equally accepted within our research application process. And so I think that's one of the fun and interesting kind of myth-busting pieces that I always work through. And the copy-paste bias that leads to it, where we just have historically excluded female persons and therefore continue to do so today.
Thanks so much, Danica. Colleen?
I think the myth that I want to bust is this idea that sex and gender are the same thing, and it ties into what you're saying about our research programs. So sex, as Sandra said, is biology, and every cell is sexed. And what that means is that every cell in your body has either an XX or an XY chromosome. And that will dictate how every protein, every amino acid, everything in your body is built based on that. And gender are psychosocial factors, and we started collecting gender factors, and everyone thinks gender identity the minute we say gender. How do you identify? But that's one of the factors that we collect when we're looking at the gender side of healthcare. So we collect in four dimensions: your gender roles, gender relations, institutionalized gender, and then your gender identity, how you identify. And we did a study across Canada, and we collected data on men and women who had a heart attack under 55 years of age across Canada. And the thing that we identify, and we collect every biological thing you can imagine for the reason for that. We also collected all these gendered factors, and we created a thing called a gender index. And a high score on a gender index was behaviors typically ascribed to women. Now, men had high scores. Some men, or males in our study, had high scores on that. But what we found out at the end of the day was the people who reported high scores on the gender index regardless of their sex, regardless if they were male or female, if they did childcare, if they were working outside the home or working for free in another facet, women or people who scored high on our gender index were 4 times as likely to return with a second heart attack in that first year. This had nothing to do with biology. It was the gendered factors. So we've always, when we mash them together and say sex and gender are the same thing, we actually miss all of our health outcomes and health behaviors that we need to measure in order to truly capture healthcare.
Thanks, Colleen. Carmen.
I've been trying to decide what myth to tackle. So much of what you said in the opening is stuff I might have talked about, but we should be able to assume, maybe you do assume, that because half the population is female and half the population is male, is that they get treated the same in the health system, that they get treated the same in the education system. But they don't. That is absolutely a myth. I specifically want to talk about obstetrics and gynecology, OB-GYN, that's what we call it. And we assume they're kind of synonymous. They go together, they're always presented together, they're trained together, so we think they're interchangeable. And we're assuming that that specialty will take care of a woman's health through all of her unique ages and stages of her health journey. But the reality is that the health system favors obstetrics, incredibly so. There were probably 50,000 births in an average year in Alberta. At that same time, there were 500,000 women that needed gynecological supports. The funding is about 75-25, and that's obstetrics to gynecology. So, horrible area of underservice. I hope I get to talk about it more, but there's your Mythbuster.
Kind of goes back to what gets measured gets done, right? And
Absolutely.
So if we, for obvious reasons, we value and we measure maternal and infant mortality, then our system's built around that, right? And
It
then
is
we miss
built around that.
the next ages and stages throughout the entire woman's lifespan.
And I should have mentioned also, if we put urology in the mix, so men's sexual and reproductive health into the mix, the support to that area is off the charts compared to women's health. And nobody did it on purpose, but it's time to recognize it, embrace it, and make a plan of action to change it.
Awesome, thank you. Okay, let's switch gears a little bit. And our friend Danica here was just jet-setting and came back from New York in the middle of the night, or really early this morning. She was at the UN Commission on the Status of Women. And so, Danica, I'm sure you have some really great perspective on some leading advancements or some kind of innovative opportunities in other jurisdictions. What are some opportunities that you're seeing out there?
I think one of the really exciting things. Test 1 2 1 2. 1 2 1 2. Sure. Here, I'll just trade you. Oh my gosh, my voice sounds awful. Okay. So I think one of the really interesting things that I'm starting to see, which is really exciting, is, and I think this is where we're going to see a lot of success and critical change over the next few years. In women's health and in female health in particular, where we have had focus has been deep dives in specific verticals of health, i.e. heart and stroke, i.e. obstetrics, i.e. gynecology, i.e. fertility, whatever those things might be. But one of the things, and there was just an announcement about it yesterday, that was really exciting to see, was that funders are now specifically looking at supporting people who are and organizations who want to address a system change. So if you're applying just for heart and stroke or just for urology, they want to know that the changes that you're creating are implementable across different health verticals and different areas of sex and gender inequity. And so YDF is the organization, in case anybody needs money, just announced $60 million in funding to organizations globally who are addressing a band of health needs and digital health needs and not specific verticals. And I think when we talk about this, we see these problems in every area of health. And so if we can address the system of health versus specific health issues, that's where we're going to see incredible change happen very quickly.
Thanks, Danica. Colleen, you do quite a bit of work with the Canadian Women's Heart Health Alliance and a lot of work kind of in education and awareness. What, in your opinion, are kind of the most important kind of cultural shifts or things that people need to be aware of, or that we need to be aware of as a society when it comes to these inequities?
So I was really fortunate to get, it was mentioned, the Caverson Chair in Mature. That actually means midlife, women's health. I keep saying we need to change the name because mature to me means old lady, and although I'm an old lady, we're looking at midlife women's health. I think the work that we've done with the heart and stroke is doing it in the female realm for cardiovascular disease, but really heart disease for women is the canary in the coal mine of women's health. Because what we've identified is in women's heart health is that we haven't studied women, and so we don't know that the treatments work. So when they don't work in the system, they turn around and say to the woman, something's wrong with you. So a woman comes in with hypertension or high blood pressure, and we have the first line of defense is this drug, and we'll put you on that drug, and you go away and you come back saying, oh, blood pressure's no better. We've got a second line of defense, we'll put you on that. And so on and so to third and fourth line, and then they say, something's wrong with you, because these drugs, we know they work to bring your blood pressure down. But when we have started to look back at the evidence that were used to say that those are the drugs that work for each of them, there are at a maximum 30% of the trials include women. And some of the drugs and procedures in heart health or heart care had 0 women in the trials that are used to create the guidelines that we use to treat women. And so when you're talking about the ethics, we actually are getting to a place in our ethics, and we can now make an argument because of the data we've been able to collect to say we can't compare to men anymore because A, we're different. We are not small men. We have different biologies. But also the fact that there's so much variation in women that we can't actually identify that one treatment works for one age group of women. And the other thing when I was mentioning about the Caverson Chair is that that's giving me the option, I just have to study women because my chair is in women's health research, so yay. The reason I say that is because we did a study on women, we submitted it to a manuscript in the States. It was incredible looking at the life stages that a woman is in and showing the differences, and they said, the editor came back and said, could we just see what the men are at those, and I said, well, we didn't collect any data on the men. We were looking at the variation in the women. So that's still out there in the academic world, that our gold comparison is men. But because of heart and stroke and the funds and our ability to do research, we now are looking at the variation, but not just variation in women, but based on what life stage you're in, which really, really matters. And when I say what life stage you're in, it's what is your menstrual cycle doing? And my husband keeps saying that I shouldn't be talking about the menstrual cycle. It offends people, and you're the only one offended, Adam. But it really matters because from 12 to 52, this incredible, from an AI perspective, this incredible algorithm of hormones are telling your brain what to do, that tells your pituitary gland what to do, that tells you your ovaries what to do. That keeps happening every single month from 12 to 52. And the only question a woman ever gets asked when they walk into the healthcare system is, when was your last menstrual period? And then they stop asking that question at a certain time. So we've identified in the heart world, and I think it's going to apply to all of women's health, that an early period, less than 11 years of age, older than 14 years of age, if you had crazy periods when you were young, if you had complications of pregnancy, those are all associated with early heart disease because it's doing something to your vascular system. So what we're doing now is we're collecting the data on all of that. We're getting women to come into our cohort and say, did you have any of these? And so we can actually turn around and say, It's associated with women's health. We have to be doing those assessments on every woman that walks in here, regardless of age.
And I just want to add on to that because I think it's really interesting what you said on the ethics process. So there was this wonderfully scathing report that came out in 2023, and this is a conversation we have all the time at my Northern, and your story also resonated with me on that, is that, well, we included female identifying and women presenting persons. Okay, but did you measure them any differently? Did you let the results emerge to be different, or did you control for that variability across not only sex and gender, but reproductive life stage as associated with those differences? And with that, that's where we see that staggering 75% stat on adverse effects when treatments and diagnostic processes go to market and are rolled out in the population. So it's really exciting that at a systems level, we're starting to, in the ethics process, say that that's not sufficient. But then also we need to go through our reviewers and through the cultural changes that allow us to really push on that and recognize that because of the dearth in the data, sometimes we have to have papers that specifically address women's health and female health.
I'd like to add on that as well, in terms of what Colleen and Danica are talking about. The other issue is that women don't take care of themselves, and depending on what stage of their life they're in, whether it's puberty or family planning, or they're becoming more mature and they're taking care of parents and kids, and then they go through perimenopause and menopause and postmenopause. Depending on what's going on, the one constant through all of that is sort of this superwoman syndrome. And so when they do finally say, I'm just not well and I've got to do something about it, if they go to the doctor and the doctor says it's normal, they accept that too quickly. And there's no data to back it up. There's no technology to arm those women with evidence that would allow them to challenge a system that is quick to dismiss them and biased. And you know, when a woman is having symptoms, the doctor's going to be thinking, well, you're just under a lot of pressure right now. You have a lot going on in your life right now. And so it's easy to dismiss. So we need the data, we need the tech, and we need women to take authority and really understand what's going on and demand that the system support them in the way it does in a lot of other instances.
So we've actually been doing that. Like, I'm so happy that you brought that up, because in the Canadian Women's Heart Health Alliance, it started 5 years ago, and it's every discipline and women with lived experience across Canada, because 78% of women going in with a heart attack, they were getting their diagnosis missed. In Alberta, we have 300 women a year that go into an emergency department, are sent home, and come back within 30 days having had a heart attack. And that's not counting, that's 300 women a year. And that's not counting the women who went home and died. And that's because we're not recognizing the signs and symptoms. So we got together as the Canadian Women's Heart Health Alliance, not only to arm women with this knowledge that, yes, you need to say it's your heart. Here's the evidence that you can go and say, look, this is what's happening to me. But also to talk to women about the language they use and how to navigate our system. So women don't use the word pain in the heart field. They say, I have discomfort or an aching or a burning. And I was talking to an emergency nurse when I brought my mom into the emergency department, and she said to me, at triage, if they don't say the word pain, they don't get into our heart pain protocol. So that means that we're now counseling women, saying, use the word pain. Don't say it's a discomfort. And if they say on a scale of 1 to 10, say it's a 10. Because the system, if you say, well, it's a 3 and it's a discomfort, well, it's not her heart. It's probably anxiety, which is what women get diagnosed with when they're actually having a heart attack.
Can I say
Carmen,
something?
yeah, add to that. And then I wanted to ask you a little bit more about some of the work with the Women's Health Coalition.
So Colleen's saying we have to be able to talk about pain, and women need to say it hurts and they need to rate it a 10. It immediately came to mind for me. This is real data. In Alberta, there is an urgency rating that is monitored. It's a performance tracker in terms of, and I'm focused on male genital health and female genital health comparisons. So those are two areas that are tracked. Male genital health conditions requiring diagnostic or procedural surgeries are rated as urgent 10% of the time. Women's similar tracks are rated as urgent or semi-urgent just over 1% of the time. What it means is that women are being bumped out of surgery. They're being postponed. But that's happening because they're not advocating for themselves and their physicians aren't advocating for them. The male physicians are advocating for their male patients with vigor, and they're going to the front of the line. And the data will help. The data proves it's a problem, but the data could also help us overcome that.
So in your work with the Women's Health Coalition, then, Carmen, what are some policy changes that you're advocating for? I know you do a lot of advocacy work, and what are, at a policy advocacy level, what are some systemic changes that could, to Danica's point, be kind of cross-cutting across all of these areas?
We have a mantra that gynecology should be the last stop, not the only stop. But one of the biggest weaknesses in the system is women's health in primary care. A man can walk into any doctor's office and expect to get a DRE. Does everybody know what that is? Yes? No? Hands up? It's a digital rectal exam, and it's the early indicator of prostate cancer. A woman cannot walk into those same clinics and expect to get a pap smear. And so we've got inequities just in terms of services, and there's a whole bunch of reasons that that's the case. So we really have to disrupt our thinking about women's health in primary care. The current system is hard to move, but we can bring in new systems. We can bring in innovation. We can use digital health, but we really have to put a spotlight on gynecological health in the primary care system. Federally, I think what we can look at is insist that the Gender-Based Assessment Plus program be more stringently applied to health, and I'm definitely going to look at it in terms of specific female-driven health systems or female-dependent health systems.
So I would love to. I'm so glad you brought up the GBA Plus program. So this is my favorite thing. I got to present on it to the UN in November at the United Nations Office of Outer Space Affairs event, looking specifically at life sciences. So it turns out women can go to space too, and we need to be able to support them when they're there. And one of the things everyone was very, very proud of was the GBA Plus, and this is my favorite stat that I got to prep for that and that I get to share on the regular from a policy perspective. GBA asks us to include women and female identified persons in the building process of technologies and in the running of organizations. However, not only in the GBA Plus program, nor any other government in the world, in our procurement processes, do we require that technology works on female bodies. We only require that females build it, which is a shocking oversight in policy. So I love the GBA Plus. I make all of our staff go through the GBA Plus training program at my normative, but it is an incomplete tool and it has so much more that we can do with it, not just from who's at the table from a building perspective, but who's being impacted by the things that are built.
Thanks, Danica. Continuing on this kind of vein of maybe some technology and innovation procurement, I guess I'm just, we know femtech is sort of a budding market. Sometimes it's talked about as like a niche market, which is kind of funny to me when when we talk about sort of the market opportunity in women's health. But Danica, what are some kind of technology solutions, data-driven solutions that you're seeing that you think might, start to become maybe more mainstream?
Oh, I think that's really interesting. So I think right now we're going through, I would call it like the baby steps of femtech. So right now, organizations and individuals and researchers are founding projects that specifically address female health needs because there's such a big lift that has to happen there. But above and beyond that, it's not sufficient to have health be health and then women's health be this other vertical outside of health. And so I think that the meaningful next step and the true innovation is that everything's baseline accounts for both sex and gender differences in their algorithmic capacity. And I'll give a really easy example of that. I think there's a few things. I like to include not just biology and sociocultural differences between sex and gender, but also morphology, because there are a lot of people who have different morphological features that could be attributed to either or anywhere in between. And so one of my favorite things or examples is like a really nice fluffy one that's not hard is when we look at the data collected from like a smartwatch on ambient movement in women presenting populations. If you are a woman, odds are the same hand that you put your watch on is the same one that you carry your purse on, and so you don't swing your arm. And so the records on how active our women identifying population is a gendered misrepresentation due to the fact that we often carry purses. Likewise, the algorithms that underpin it from a sex and gender variability perspective, this is, again, trying to like lob fluffy things. There's a lot of problems in the AI space. When I'm not pregnant, I hate being active when I'm pregnant. Turns out I thought I'd be like a sporty pregnant lady. Not me. No, 0%. I hate it. When I'm not pregnant, I love being physically active. Every algorithm that I've ever used has measured me as a percentage of my husband's output. So I go for my like a caloric expenditure or a heart rate efficiency or a heart rate variability or a rest and recovery. My watch, when I was still wearing it during my first pregnancy, I went for a hike with my husband, and he was like, your heart rate's really high. Have you gotten out of shape? I was like, I'm 5 months pregnant climbing a mountain. Leave me alone. And so when I think about the biases that entrenches in the systems that when we use these devices in our digital healthcare systems, they accidentally have the capacity to perpetuate the inequities that we see today and actually further entrench them. And so I think there's a huge opportunity in the femtech space with people who are addressing those algorithms head on, but it's about getting those algorithms into the mainstream tech that is the important next step.
One thing about, I've been really delving into the menstrual literature, actually learning it again myself so I can really understand it and what's happening in a woman's life. And there's a fabulous new book out by Jen Gunther, and it's called Blood. But one of the things she says in there is that being pregnant, and we know this in the heart health world, being pregnant is the metabolic equivalent of doing the Tour de France. And what that means is like your blood volume doubles, your heart is working over time. All of those things that we just take for granted as being normal. And I think that's part of the issue in the women's health spectrum is that, you know, a woman will say, you know, I'm not sleeping. They're going through perimenopause. I'm not sleeping. And they say, don't worry. You'll sleep. It'll come back to you. You'll have 4 or 5 years of this. You'll be fine. And as I'm thinking about that, I'm listening to a book called Why We Sleep. And the physician, the neuropsych physician is talking about it. And he says they've identified a direct relationship between sleep deprivation and Alzheimer's. And I'm thinking, whoa. Like 2/3 of Alzheimer patients are women. And who doesn't sleep? Women who have babies and women going through perimenopause because we think it's normal. And I'm saying we've got to throw out anything that you've ever thought was normal. It's normal that your period hurts, or you know what, we'll put you on birth control to clear up your acne. Like, what? You know, those aren't normal things. It's not normal to have to leave a room because you've soaked your clothes. We actually have treatments for those vascular symptoms, but society still thinks it's all normal. So I think the whole myth busting is to say, it's not normal that you don't sleep, or it's not normal that you're throwing up through your whole pregnancy. It doesn't mean that it's necessarily a health consequence, but someone has to check on that. Someone has to say what's going on in your body. And we don't have any evidence on that at all. Like, we just don't.
I really like where Colleen was going with this, in that use of the word normal. Just because something happens all the time doesn't make it normal. And that's the paradigm we need to shift. And menopause and aging is a huge part of that. You know, one of the myths I was going to use to start this conversation was that STIs are a condition of promiscuous youth. In fact, STIs are most prevalent in seniors. And the incidence rate is higher in female seniors. And the reason for that is because men who suddenly have pain urinating, they're going to go talk to their doctor. They're very comfortable with that. They always have been. A woman who's older today, if she's experiencing those kinds of things and she's living in a communal center, she's going to go undetected because she's not comfortable talking about it. She's not willing to admit she's sexually active at 75, maybe with multiple partners. But but it's because of the norms and the taboos. We have to quit using words like normal.
Awesome. So as we wrap the panel up, let's do kind of one last kind of quick round. I'm going to ask you, what is the single most impactful action we can take starting today to make a substantial difference in women's health? So kind of call to action for the room.
So I'm going to start. We have started, it's called the Chaser Sex and Gender Questionnaire, and we started collecting this data on women. All of their sexual, the biological history and the gender factors that affect your health. And to me, we need to start collecting that data, and we need to start sharing it with everybody to say, hey, look, we've got this cohort, and everyone should be collecting that. From the minute a woman walks into a health care or is asking about their health, we need to be collecting all of that information.
I think there's one that's really easy that I think would be my ask based on this conversation, and I hear this one all the time as a currently pregnant individual, which is to remove the word normal from our language. It's so awful. It's the most disenfranchising thing in the entire world to be like, I can't sleep, or I'm in chronic and excruciating pain. For someone to say that's normal, that even as a person educated in the field, it immediately you go, okay, and then you kind of sit down and you kind of shut up. But it's not. And so if you research in the women's health space, or you practice in the women's health space, or you advocate in the women's health space, I think removing the word normal from your vocabulary would be a really meaningful personal action that we can take.
In fact, we don't know what's normal for women.
No, we don't. Data's not in.
So I have a call to action I want to leave you with, but I want to add to what Colleen said. Not only do we have to collect that data, we have to be willing to share that data. There's some really exciting work going on at the U of A under Dr. Ross Mitchell about creating open source data that will drive AI for health innovations and triage and diagnosis to take some of the mystery out of what the experience means. My biggest call to action on behalf of the Women's Health Coalition will be to encourage everybody to encourage the women in their life to take authority over their health experience. The system is not well educated about what they're going through. They're not attuned to what the opportunities for treatment are. They can't measure the degree of pain you're going through. So whether it's your mother, your partner, your sister, your friend, your colleague, your employee, they have to start talking about what's going on and not with sugar-coated vocabulary. They need to be able to talk about where they hurt, how much pain they have. If sex hurts, they need to be able to say sex hurts, because they're not going to get any attention unless they be really bold and provocative in the conversations about how they're feeling, even if the system isn't ready for it.
Thank you all. I'm going to wrap up by thanking Health Cities for bringing together this incredibly important conversation. I think this is just a start. We probably need a lot more of these. We could probably host quite a few more panels just like this. And thank our incredible panelists, Danica, Colleen, and Carmen. Moving forward requires understanding the broader effects of the women's health gap. We need action on 6 fronts. We need more awareness. So go home, tell your friends, tell your family, continue this conversation. We need to enhance access to sex-appropriate care. We need to systematically collect and analyze sex and gender-specific data. We talked about that quite a bit today. We need to close the research gaps. We need to fund and incentivize this work. And lastly, we need policy that supports it. This will take an ecosystem approach. This is not a health systems problem. This is also a financial systems problem. This is an academic systems problem. This is a political system problem. And let's not be lulled into thinking that with just a little more hustle, a little more girl boss power and inspiration, she too can have access to sex-appropriate prevention, diagnosis, and treatment. There's no one program, there's not a panel, and there's not an app that's going to solve this deep inequity. Each solution that comes forward is a small lever that will eventually open a big door. So my call to action is that we work together, that we commit to action and innovation in this space,
and hoping that that will lead to timely, equitable, and sex-appropriate care for half the population.
You are a very good audience. You know it's a good panel when people are literally leaning forward and dead silent, just fascinated at every comment. It is like 51% of the population is female, and it kind of matters and is important to everyone, whether you're male or female. Thank you so much for those remarks. That was incredibly insightful, and what a way to end such a fantastic conference. I love the line throughout what we think is normal. That could be transitioned to innovative thinking, which goes across all of the topics from today. There was another quote by Colleen in the Indigenous panel, which is nothing for us without us. I think that lends itself to the last panel as well. So that's two of so many insightful comments, and I hope that Sandra, your opening and closing statements, all of the panelists' views, any insights that you're taking goes far beyond this conference room today, because this is important stuff that should be shouted from the rooftops. Thanks again to Health Cities for putting this on, to our presenting and community sponsors. It's been an honor being your MC, being able to introduce such fascinating work and people throughout the day. And to close this off, I'm going to ask Red Joseph, the CEO of Health Cities, to come back up for some closing remarks. Thank you so much.
Well, that was inspiring. For those of you who know me, you'll be surprised at what I'm about to say. I'm left speechless. And that doesn't happen that often. I want to thank you all for coming. Panel members, I really want to thank you for being bold, sharing your true thoughts. There's certain conversations that we need to have, and I think we've started those conversations here today. The next step is how do we engage, how do we move forward? And we are a tiny team, Health Cities. They're all right there. That's it. That's our team. But I think we have a bold vision in terms of where we want to go. And the only way we can move that forward is through partnership. So thank you all for being here today. But I am looking forward to your partnership going forward so we can move the needle in these areas that we talked about today. And that's really all I wanted to say. I wanted to thank you all for coming to Red Deer. It's great to host here in central Alberta. And everyone have a safe trip home. Thank you.